Assalamu alaikum. I can see Farhan. आपकी आवाज नहीं आ रही. Can you hear us?
माइक खोल लें.
ठीक है, अब आ रही है आवाज. बताइए फरहान.
Okay. Very good afternoon and assalamu alaikum to AFIC Cath Lab B. We have two cases this afternoon and we'll be transmitting one case from this lab. I'll introduce you to the case. Our patient is 60-year-old hypertensive. He presented initially on 18th of July this year with a non-ST elevation myocardial infarction. His clinical course at that time was unremarkable and his biochemical profile is also normal. His creatinine is 1.2 and hemoglobin 14.5. Next slide please. We did a coronary angiogram on him and we found two vessel disease. I'll just show you an angiogram. His LVEF is 60%, so he's got a good LV function. And his syntax score you can see on the screen and PCI and CABG mortality. So instead of wasting time, we'll just go to the angiogram. I'll show you the angiogram now. Please, angiogram. Okay. Fell up. Okay. Can you see the angiogram running?
Yes, we can see that.
Okay, so here you can see there's a very large left main stem, and there is a proximal LAD disease, and there you can see a trifurcation branch, and we have a dominant circumflex. As you can see, the LAD has got a long diffuse disease extending up to the mid-course. And RCA is non-dominant. So he's got a good LV function. So the case is open for discussion. I would like to have the opinion of the panelists.
Right. On the panel, there are Dr. Mansoor Ahmed, Dr. Tanvir Rab, Dr. Sohail Aziz, Dr. Asad, and Dr. Shahid Hamid. I'll start by asking Dr. Mansoor Ahmed. Well, he's just joined us. Let's start with Sohail. You've seen the case. What's your comments?
Thing because the traffication is significant, it has obstructive flow that's probably producing symptoms, so you have to deal with that. And the LAD is really very osteal. In fact, if ideally one could do an IVOS and see what the left main is like, and if it's diseased, then naturally you have to come across it. But then you'd have to open the struts for the traffication. If it is not, I mean, a lot of us would probably, in our environment, try and do an osteal stenting, which could be a very tricky one. So I'd love to see how it's done.
Right. What's your plan, Farhan? What's your way of thinking? Then we'll ask the next panelist to give his comments. Sohail thinks that IVOS-related strategy. Yes.
In my opinion, I think we have discussed with the Dr. Nehat also, there is a significant disease at the LAD ostium, and we all know that this disease generally extends back into the left main stem. So there was a very serious discussion that we should stand from left main into the LAD for a complete job. But then if you look very closely, look at the left main stem, it's a very large left main stem. There's going to be a big discrepancy between the size of the LAD and the left main stem. And from the angiographic views, we have seen very closely, there is hardly a disease in the left main stem.
Can you show us the AP caudal view? Farhan, can we go on the, you're showing us the RAO view, can we see caudal view? Yeah. All right, this is a good view. So what about that disease in the mid ramus or high OM? I think it's
we are going to treat that as well. But as you know that there's if we place LAD stent, LAD osteal stent only, then there is a chance that the intermediate can get pinched. So what we are planning to do here is that we will place a wire in the intermediate branch, and then we, instead of stenting the mid lesion first, we'll keep a balloon along with the stent in the intermediate branch, a stent in the LAD and a balloon in the intermediate branch. That's how we intend to save the intermediate, and if everything goes well, then we will stent the intermediate lesion later on. If there is a problem, then we can, stent from the intermediate ostium into the covering the that intermediate lesion. So it will become a V-stenting.
So, Fransa, will you be doing a osteal stent?
So let's start.
Yes.
Let you do the work, and then
That's
we'll
what the
discuss
plan is.
among our panelists. Sorry. Yes.
So,
I was asking, do they
if you
plan an
want, we
osteal
can-
stent?
Yes. They're going to nail it, and they're going to have a balloon, safety balloon, and I think that's the way I would do it. Asad, what would you think?
I agree. I think, but my only issue is I think we can just even stent the ramus beforehand because the ostium is clean and keep that balloon, stent balloon there. Just if there is any pinch, you can just open it. I just in the cranial view, I thought there was just a left main disease. Maybe not a bad idea if we can IVAS it or something. In your previous view that you were showing here, no, the other one, RAO cranial, yeah, here.
Tanvir, I think
so here it looks like left main is
shown
involved.
that whenever there is osteal LAD disease, in 70% of cases, there's always some involvement of left main.
That's true. So I think in this particular case, the way I would approach is I'd fix the ramus lesion, leave the wire there, stent from the LAD back to the left main, pot it, and then see what it looks like. You may not have to dilate the other branches.
Mansoor, your comments?
Yeah, I think I would like to see the spider view as well, because the angle is not very clear in the caudal view. To me,
yes, Farhan, you carry on, and then we can discuss.
I think
Mansoor wants to see a caudal view.
I just want to say one more thing here.
Yes,
to
Farhan.
start
There
with,
was an issue of the disease in the left main stem. We have done an IVAS, and if you want, we can show you IVAS now, or you want to see it later on.
Oh, we'll see it now.
Yes, I think we
please,
should
want
see
to
it now.
yeah.
So we can show you the IVAS.
Yes, you can show us the
Yeah,
IVAS
please
while
show
you
the IVAS,
continue
yeah.
with your work. So you've already wired and you have done the IVAS.
We have wired both branches, and we have just did an IVAS just to be sure that there is no disease in the left main
Yes.
stem.
So let's see
So
the
we are
IVAS,
showing you
and then
IVAS
we
now.
can go live and see what you are doing.
There's somebody standing in
IVAS
front
के
of the
सामने कोई
IVAS.
आ रहा है, आप IVAS को मेन स्क्रीन पे ले आए. सिनी को हटा के IVAS को मेन स्क्रीन पे ले आए. या चलें उसी को दिखा दें.
चल दिखाएं जी मोशन. बोलते जाना.
Can you keep on describing to us the IVAS, Farhan?
A lot of diffuse disease all along.
You can see the
Yes.
arc of calcium in the mid LAD. And you can see the disappearance of echoes. And as he's pulling back, you can see there's diffuse disease in the mid LAD. The diameter of the distal LAD was 2.5. Then in the middle it is 3, and the proximal LAD is almost 4 millimeters. Here you can see the circ is coming up, intermediate and the circ branches, and this is the left main stem. You can
And
see
there's a big
it's fairly
mismatch.
free from the disease.
It's around 5.5, 6 millimeter left main.
It is a 6 millimeters left main stem, and you can see that it is free from significant disease.
So
That was another
Shahid,
reason why we chose to just stand there already.
And what was the MLA that you got on the left main?
What was the MLA that you got from the left main?
At the
we
tightest
will
point.
just calculate now.
Yeah.
We can just calculate now.
हाँ, शाहिद आप बताइए आप लोग
Calculate
इसको कैसे डील करेंगे?
हाँ जी.
Mike.
I think it's a very big left main. I think the first effort should be to spare it. I mean, try to stand beyond it. And the other thing is a lot of calcium in LAD. Now it looks like, I mean, on an angiographic view, it doesn't look like a lot of calcium, but here the arc is really
I hope you can
nearly
see the
360 degrees.
Yeah,
So
yeah, 22 millimeter, yeah.
So some calcium modification strategy.
Can they show us the left main close to the LED?
LED, yeah, coming from left main, LED coming back into the left main.
वो फरहान कह रहे हैं कि अगर आपका जो लास्ट वो पुल बैक है ना फ्रॉम एलईडी टू लेफ्ट मेन उसका स्टिल जरा
we'll
दिखा
just
दें.
yes, okay, we will just focus that.
This is the academic for our fellows कि ये बड़ा
Ostium
important
into
है
the left main stem.
कि इस टाइप की डिलेमा जो है उसको कैसे डील करें.
Osteal
It
ठीक है.
is the LED.
लेकिन
Okay. Come back.
Yeah.
Come back a little bit. Come back. That's it. Oh, a little bit more.
अभी तक लेफ्ट में नहीं आया.
Yeah. Yeah. ये left main है.
ट्रैफिकेशन आई ना.
और
ये ट्रैफिकेशन है ये.
That's
ये
it.
यहाँ देखिए.
That's it. ये left main.
ये ठीक है.
This is the left main.
Yeah.
I think 2-3 millimeter तक पीछे.
No, there's a little bit of plaquing, but little bit of nodular calcium, nothing much. Okay, Farhan, आप शुरू करें, हमें फिर we'll keep on discussing. आप बताइए.
Thank you.
First, round intermediate balloon.
Intermediate balloon, please. Why don't we dilate the LED first?
Tanvir, I think in US, like the case we saw yesterday with a EDP of
2.5 balloon,
21 and a EF of 40%,
2.5
and Pella and everything else.
2.5
Do you agree that that's not really relevant to us, that they used, you know, an Impella 25, 30 lakh rupees? We do these cases every day. We do have mortality, obviously. But how much difference is there actually? Data hasn't shown us
in this case, probably not. In this kind of case, I think nowadays Impella usage has gone down a bit, okay, because of the data from Washington Hospital Center in Europe. But I think certainly if somebody has awful disease, multivessel, low EF, very high DP, and you need to do it, a high-risk procedure, yeah, then yes. But I think in a case like this, where I think you can get in and out pretty reasonably quickly, with a good operator, you'll be fine. And this should be a single stent strategy. There's no reason to do otherwise.
Right, Asad, you want to say something?
Yes. So one of the issues with Impella is the main complication with Impella is in the groin. So loads of interventional cardiologists, even in US, started putting it in without actual peripheral training. So that was one of the reasons why all this Impella use is going down. So the complication.
I'll fix that first before I do anything.
Right, Farhan, हमें बताइए क्या आप कौन सी वायर्स हैं? ये तो वर्क हॉर्स वायर्स यूज किए हैं. अभी क्या नेक्स्ट क्या है? आप बलून करेंगे?
Wire कौन सी? There is a BMW in the LED and Sion wire in the intermediate branch. And we intend to dilate the LED with the non-compliant balloon first because there is calcium. And our plan is to first dilate the LED and then keep a safety balloon at the ostium of the intermediate branch while we stent the LED.
अच्छा ये बताइए कि why not upfront rota? उसमें साइड ब्रांच भी स्पेयर हो जाएगी, ऑस्टियल एलईडी भी है, कैल्शियम का आर्क भी अच्छा खासा है, तो देयर इज अ क्लिनिकल इंडिकेशन टू रोटा. रोटे में फिर आपको शायद वो बलून भी ना रखना पड़े रेमस में. Why not rota? Is it just because of cost restraint?
I think the ostium of the LED is okay.
Yeah.
There's not enough calcium to rota there. Nadeem, there's not enough calcium to rota there.
We can delete it. Intermediate.
Maybe there's better for cutting balloon.
Contrast.
Check dono.
Contrast. Yes.
Pull the intermediate wire little bit.
Cutting balloon.
Delete it in intermediate.
Yes. इस एरिया में recoil काफी होता है ना. मेरा अपना ख्याल है कि जब इसको आप प्री डायलेट करते हैं ना, इसमें इतनी बैलेंस सीडिंग होती है, इट्स कीप स्लिपिंग एंड कॉज नहीं इस ऑस्टियल्स के अंदर.
जरा बताइए व्हाट्स योर कमेंट्स, आप लोग आपस में कर रहे हैं.
I was saying that when you try and spot stent this ostium, the balloon would tend to melanseed. It tends to melanseed. So for this situation, maybe cutting balloon is better to give you a clean and a precise dilatation without slipping.
अच्छा, फॉर द ऑडियंस जो लोग बैठे हुए हैं यहाँ फेलोज, ये बताइए कि ये लोग एक बलून रख रहे हैं रेमस में और एक स्टेंट डालेंगे, नेल करेंगे. अमंग द फेलोज एंड द जूनियर्स, ये इस स्ट्रैटेजी से कितने लोग डिसएग्री करते हैं? हाथ खड़ा करें. अच्छा, आ जाइए आप माइक पे आ जाइए.
आप हमें भी फेलो समझे.
आ जाइए जिसने हाथ खड़ा किया. इनको माइक दें, अपने को इंट्रोड्यूस कराएं और बताएं आप क्या करेंगे. डॉक्टर साहब माइक पे आए जी, अपने को इंट्रोड्यूस कराएं और बताएं क्या व्हाट यू वांट टू डू.
माइक ऑन करो जी.
माइक खोलें उनका.
So I am Dr. Ghufran Adnan, Senior Registrar, Wazirabad Institute of Cardiology.
Senior Registrar where?
Wazirabad Institute of Cardiology.
Wazirabad, बताएं.
Yes, so I will just keep the wire in the ramus and I will balloon the LED and will stunt the LED. I don't think so we need to keep the balloon in the ramus.
Why is that? आपको safety, आपको कोई plaque shifting का danger नहीं है?
So yes, there is some chance of carina shift more, and if there is a plaque shift, then you need to put the you need to keep the balloon here, but I don't think so. There must be more carina shift in this kind of lesion.
All right, good. That's a good comment. Ji.
So I think they have ballooned the lesion in ramus. I thought they were going to do it after LED. That's what they were saying. But they've already ballooned it.
जो वजीराबाद से थे, इसमें इशू ये है कि आपको इंटरवीन तो करना है रेमस में, तो जब आपको रेमस में इंटरवीन कर ही रहे हैं तो यू माइट एज वेल वही वाला बलून 2 मिलीमीटर का जिसको आगे डायलेट किया है वही ज़रा पीछे खींच के लो प्रेशर पे रख लें वाइल यू आर स्टेंटिंग इनटू द एलईडी, तो प्लाक शिफ्टिंग की चांसेस या कराइना शिफ्ट की चांसेस कम होती हैं. सो और तो कोई इसमें, हाँ अगर कॉस्ट के इश्यूज़ हैं और अगर आपको सिंगल वायर यूज़ करनी है तो देन इट मेक सेंस कि जो आप कह रहे हैं वी कैन डू दैट.
I think, Nadeem, at a place like this, when you talk about techniques and all, cost becomes less of an issue. I mean, you can't just, how much does a wire cost? For safety's sake, for keeping the traffication going, you have to get that wire there. If you pinch it, it'll really become a problem for you.
Right. Bilal Saab has joined us. Bilal Saab, बताइए PIC में आप क्या करेंगे इसमें, अगर आप ये कर रहे हो दिन में तो आप लोगों का रूटीन क्या है, क्या 2 वायर डालेंगे और
PIC में पहले मैं देखूंगा जाके हुआ क्या है, PIC में पहले मैं देखूंगा, मुझे तो पता भी नहीं है क्या.
अच्छा,
I'm just trying to get to the
ये रेमस और LED को ऑस्टियम को फिक्स कर रहे हैं रेमस में.
You see, there is always this big debate which goes on that if you do not intend to stent an area from the go, then do you really need to dilate that area? Because once you dilate that area, you have caused an endothelial injury. So if the endothelial injury is going to be caused by the ballooning, then you are actually mentally getting prepared that this may actually be a dual stent technique that you have to apply for.
Right.
So that is what you have to say.
Okay, I just personally, this is personal anecdotal, you know, I don't know whether others, seniors there are here who are as or more experienced than me. My own experience can be that this is not actually true in practical. Hundreds of ballooning POBAs of circumflex, especially the epicardial arteries. If you balloon gently, not cause a flow-limiting dissection, because the whole point of angioplasty is causing micro-dissections. You have to disrupt the plaque. So just small massaging, we've been massaging distal LADs, diffuse diseases, and I personally, when I fix the proximal area and there's diffuse disease, I always massage or balloon and leave it open. And very rarely, but this is again anecdotal. I don't know, we don't have the options of publishing major, now volumes, but that's my experience. So I would disagree with that point of view कि जहाँ balloon करो वहाँ ज़रूर re-stenosis की 40% chance होती है. I think 5-10% तो.
But when you're saying of massaging it out, then actually what you're saying is, sorry sir, when you're saying is that you're going to keep it at a low pressure. You're not going to go at higher pressures. One, and number two, you are not going to go at, you're going to hit about 1 to 0.7 diameter. You're not going to go to 1 to 1. So these are the facts that need to be remembered when you're doing it.
Any other comments from the panelists regarding this?
At low pressures,
maybe half a millimeter back for the LED.
If you go up to 3, it will occlude the osteum, but at the same time.
तनवीर ये बताएं कि अगर फर्ज करें आप बलून करके किसी को एक 2.5 की वैसे जो यूएस में और ऊपर स्टेंट डाल दें और बाद में वहाँ रीस्टोनोसिस हो जाए, कोई रेगुलेटरी या कोई और क्रिटिकल इशू आप लोगों के ऊपर आता है कि why have you only POBA'd and not put a stent?
No, there's no regulatory issue, but there's a ton of data published that if you balloon the ostium side branch, okay, there's a chance of dissection or restenosis. Ton of data. So bifurcation technology, if you have a lesion less than 50%, and you don't need to do anything, leave it alone. Don't pre-dilate. Now, if he's talking about a jailed balloon technique to keep the ostium open, just leave, that's a different thing. Just leave the balloon sitting there to avoid that plaque shift and don't inflate the balloon. You know,
just to keep the carina.
Sorry, interrupt. ये दिखा रहे हैं, जरा describe करिए. ये अभी आपने क्या किया, फरहान?
After during the operation,
they're quietly working away while we are discussing all this.
Work and please,
Lekin I think they need to tell us because this is the live case, so they need to. Farhan, can you hear us?
So, yes,
this is a live.
So what we have done is,
तो चलें इन्होंने ये किया कि I think they stented the LED while keeping a balloon और stent भी कोई बहुत बड़ा नहीं लग रहा to I don't know.
Can you hear me?
लॉन्ग स्टेंट है लेकिन डायमीटर कोई बहुत बड़ा नहीं है. देखें तनवीर, माय इशू इज़ दैट एक तरफ तो हमारे पास ये भी डेटा है कि आप किसिंग करें अगर एंड डू नॉट स्टेंट unless there's flow limitation or there is dissection or symptoms.
Dr. Nadeem, can you hear me now?
And दूसरी kissing balloon का भी data versus, so this data either way.
Can you hear me now?
That you know, some people say that no, final kissing is must. फिर अब आता है कि नहीं ज़रूरी नहीं है, फिर पॉट का बीच में आ गया, पहले पॉट नहीं था, the last thing was kissing, and this was been done for chunks of 3 to 4 years में जो data suddenly हमारा change हो जाता है. अब स्टेंट के पीछे जाके हम balloon रख लेते हैं to save the side branch. So I think there is, I agree, the data is both ways, tons this way but also this way. It depends on individual cases. My own view जो हम लोग fellows के लिए कह रहे हैं वो ये कि अगर आप एक proximal LED में, for example, you fix it and stent it properly, and there is a discrete 70-80%, या diffuse see कोई 70-80% disease distal में apex से let's say 15-20 millimeters upstream, तो उसको अगर आप balloon कर दें 2 millimeter से उसको gently, तो there is no harm, rather than leaving a 70-80% narrowing in the apex just because कि आपको फिक्र है कि लीमा या कहीं ना लगे.
Can I respond for you, Tanvir?
Yeah, sure.
I think we're confusing 2-3 things here with this statement. Number one, if you have a side branch, you want to kiss it, you can't recross it, the outcome's going to be bad. So if you say this, I can't cross it, so the data is conflicting, it's going to be all right, that's not the right thing to say. If you were supposed to give it a kiss, you could not recross, that's a separate thing. It will have a more ISR and a bad outcome. The other is, if you balloon the side, stent the side branch, the main branch, and you cross over and you balloon the side branch, then what happens is that the struts on the far side get pulled in, and they don't get approximated there. That's again a bad outcome.
सोहेल वो बात नहीं, मैं सिर्फ बात कर रहा हूँ कि हम लोग बात कर रहे हैं कि कहीं बलून करो या तो करो ही ना, या बलून करो तो जरूरी है कि स्टेंट करो. This is the talk. We are not talking about bifurcations and things. We are just talking about कि कहाँ बलून करो तो do we have to stent?
The only way to justify your thinking is if there's a flow limiting lesion downstream, your stent can thrombose or restenoze. That's the only argument that may go in your favor. If there's a flow limiting lesion, stent might close off. Okay. Second issue, if there's minimal lesion in the osteal side branch, there's enough data to say, particularly from the Excel trial in left main, that kissing balloon had no advantage. And this now came from the ProPort study. ProPort study just came out also last year, that POT, then side branch dilation POT, may be equitable to the results you might get with kissing balloon inflation. So you have to look at the data and say where you go. But the trials have shown that kissing balloon inflation has no advantage if there's not significant side branch stenosis.
Actually, the subgroup analysis of Excel actually showed you had more restenosis and thrombus when you did kiss routinely.
Sorry, I'll stop you there. ये फरहान ये सारा ही पैनल आपस में हम लोग डिस्कस कर रहे हैं. आप जरा बताएं क्या.
Can you hear me now? Can you hear me, please?
Yes, now we can hear you. Just can you describe?
Actually, there was a problem with the internet connection, and it was showing that the connection is unstable. So we continued our procedure. What we have done is we dilated the LED with the trio non-compliant balloon, and they were the kind of balloon
जरा शो शुरू से शो करें पीछे से. हाँ, गुड.
देखिए मैं जब भी SIHD का
हाँ बस यहाँ से शो कर देता हूँ ताकि
here you can see first we dilated the lesion in the intermediate with a 2.5 balloon. Next, leave the floor, please. Next, okay. Yeah, go back.
Slowly करें. हाँ बता.
Okay. So we first dilated the lesion in the intermediate branch. Next. Then we took a non-compliant balloon for the LED trio. We gave forward dilatation at a high pressure, and we were able to dilate the LED lesion. Next. Then we brought the intermediate balloon back into the left main stem, partly in the left main stem, and partly into the intermediate branch. We inflated that balloon, and then we inflated the stent. We took a 275 48 stent. So that we can use just one stent.
What were the pressures? What were the pressures of both balloons?
Pressure at the moment is 150 or 100.
No, the balloon pressure. कितने atmosphere पे आपने?
The balloon we dilated the non-compliant balloon at 220 atmospheres.
नहीं, अभी जब आप ये जो आप तस्वीर दिखा रहे हैं, इस पे balloon pressures क्या हैं?
This was, as you know, that this stent is covering from the ostium to the mid LAD, and the diameter in the mid LAD was 2.5, and the stent is 2 cent fiber. So we dilated it at nominal pressure of 12 atmospheres, and then we have post dilated.
और वो जो रेमस में रखा हुआ है बलून उसका क्या प्रेशर और साइज है?
The Remus balloon was inflated at a low pressure, about 8 atmospheres.
8 atmosphere, and the balloon size was 3 or 2.5?
The balloon size was 2.5.
2.5.
And it was a semi-compliant balloon.
Right.
And now we have post-dilated the proximal LAD once again. We placed the intermediate balloon half into the left main stem and half into the intermediate branch. Then we took a 4O balloon, and then we inflated first the intermediate balloon, and after that we inflated the balloon in the LAD. As you can see, this is a 4O 15 balloon. At high pressure, we went up to, as we have measured that by IVUS, that the diameter of the LED was 4.5. So we went high with this balloon. We went up to 20 atmospheres. And then again we have pushed the intermediate balloon forward, and now we intend to dilate the mid LED with the 3.5 balloon. Take a picture there. Now we take a picture.
Yeah, I think we've, if you just show us or keep an IVUS, we have to shift to the other room.
As you can see, the result in the proximal LED and osteal LED is very good. The ostium of the intermediate branch is very well preserved. We will stent the intermediate branch now, and then we post-dilate the mid LED. And
so Farhan, is it possible to shift to the other room and see what they are doing while you do the IVUS, and we'll come back and see the IVUS findings?
Okay, well, I'll just make the arrangement. Bilal, sir?
So this is the strategy that personally I would also follow. I mean, I know, again, this is a bit controversial. ये जो बात कर रहे थे वज़ीराबाद से हमारे सीनियर रजिस्ट्रार, that makes sense कि normally अगर cost की और चीज़ों की और injury की problem है, अब 2.5 का balloon उन्होंने 8 atmosphere पे रखा. What is the chances of restenosis? My own experience and view would be very low, about 10%, 15%. So what's the harm? अगर वो, because sometimes what happens is कि अगर आप ये ना करें और फिर आपने LED को fix कर दिया, आपके 2 strut उसमें hang कर रहे हैं, फिर उसको आपको move away करना पड़ता है, छोटा उसको हटाओ, फिर अपना device ले जाओ. तो इस तरह ये है कि at least you won't have problems.
I think traffication में balloon inflate करना to prevent the coronary shift, उससे ISR को फर्क नहीं पड़ना चाहिए.
किसको?
कराइनल शिफ्ट के लिए जो इन्फ्लेशन करते हैं, उससे तो ISR को, वहाँ ISR का कोई डर नहीं होना चाहिए.
यार बात ये कि नहीं, my experience is कि
वो शायद 10 तक चलेगा. I would have cared like 5 or 6. And हाँ, but
IVUS कर लेना, IVUS करके देख लेंगे कितनी disruption है, क्या वो है. पहले तो हम nail करते थे ना without any balloons here.
देखिए, अब जब IVUS खुला हुआ है तो there is no harm doing an IVUS.
एक टेक्निक थी ग्रीक टेक्निक. पहले बहुत ज्यादा वो जब जमाने में स्टेंट मोटे होते थे तो वो मेन आर्टरी में रख के साइड ब्रांच से वो स्टेंट पुल करके, और वो ग्रीक टेक्निक कहलाती थी. उसके रिजल्ट्स इतने बुरे नहीं थे.
The original paper on that one said 6 to 8 mercury millimeter pressure, not anything higher than that.
So you would agree with this?
We actually used to do it, but that was mainly for osteal diag lesion that we would use this technique. Yeah, I think this is pretty good. But I would have actually stented that ramus up front and kept that balloon for carina shift, because rather than going through the struts now, if they get stuck.
So I just asked Tanvir, is he happy?
No cross talk.
Yeah, I just asked Tanvir, would he accept what's just happened? And he said only after seeing the IVUS.
Now I know.
So we need to see the
Dr.
IVUS.
Tariq is an odd man.
And if you don't have the IVUS, then what would you say?
17.
If you look at the
then you got to go local
being
I'm an even
deployed,
man.
there is a little distance between the two, which suggests that the angle was probably reasonable, and it was not even needed.
Yes.
And moreover, another point, if there is no plug, then inflating a balloon doesn't hurt, because it's flexible, its elasticity is there. It may open up and close down. Dissection takes place only when the artery is.
But I have a feeling that most of the panelists would not do this, and I agree. I mean, that's how.
If you now do the IVUS of the LED, you need to make sure that the stent is well approximated. That if it's not well approximated,
दूसरी लैब का क्या हुआ?
4 NC.
You see what problem to actually get down to this nitty-gritty detail is that the area of ischemia created by an osteal compromised LAD versus a compromised intermedius. Now that is what you actually need to finally weigh it out. If it is what kind of an intermedius it is, and is that intermedius well covered from another area also or not.
Let's
so
go
that
to
may be a way of assessing that,
please,
because many a times if a single vessel disease of intermedius only, you probably will not do anything over there.
All right, just for the sake, हमारे fellows बहुत बैठे हैं, इस तरह कितने fellows इसी तरह करेंगे, हाथ खड़े करें, या जो junior consultants हैं, कोई भी नहीं करेगा इस तरह, जिस तरह इन्होंने किया.
Nadeem, you need to know one thing.
Because we are going to stand for long.
People have done a lot of bifurcations, came up with certain, not standards of care, but we wanted to simplify the way we do bifurcations. For example, the paper with left main that we published, we want to simplify the approaches. Even the European Bifurcation Club is 2-3 volumes aaya hai. These kind of techniques are not there. Because the experts in the world have said, let's approach these things simply. So if you want to do your own thing in Timbuktu, do it. But majority of the people will do certain kind of way. And just inflating a balloon side branch, where there's no plaque there, there's no justification in the consensus opinions, okay? So anyway.
नहीं, we agree with that. No one is saying कि data को कोई ना देखे, लेकिन आपको you also must agree that over the last 30 years we have evolved, and those patients who we were doing, jailing stents without kissing balloons or something, not all of them died or something. We are trying to improve the MACE results and everything else. यूरोपियंस को लॉट करते हैं, वो डीके क्रश करते हैं, कोई लोग वायर नहीं पास होती तो वो अपनी एक्सक्यूजेस साइड से. सो आई थिंक डेटा जो आपका बेंच टेस्ट और जो रैंडमाइज स्टडीज और रजिस्ट्रीज को आप कंपेयर करें, यू वुड एग्री दैट देयर इज अ डिफरेंस. एंड हमारे यहाँ एस्पिरेशन, अब जैसे आप ये हम कह रहे हैं एग्री डेटा आ गया कि एस्पिरेशन नहीं करो, 70% ऑफ द पेशेंट्स जो CVD में प्राइमरीज 30 प्राइमरीज होती हैं, 70 to 80% का एस्पिरेशन होता है. हमने मना कर दिया, लेकिन फिर भी वो प्रॉब्लम ज़्यादा होने लगी. तो अब हम उस डेटा को लेके हम कहें कि नहीं, कोई बात नहीं, पेशेंट का आर्टरी नहीं खुल रही, एस्पिरेशन के बाद खुल रही है, लेकिन हम एस्पिरेशन इसलिए नहीं करेंगे कि टेस्ट और उसने हमें कह दी. तो आई थिंक रियल लाइफ में थोड़ी बहुत कॉम्प्रोमाइज.
थोड़ा सा एक मैं अर्ज करूं, हम जब डेटा की बात करते हैं ना, there's a lot of volume, but it's not structurally analyzed. So उस डेटा को जो analyze ना किया हो, interpret करना becomes a bit difficult. That's why it becomes anecdotal.
अभी US में कुछ लोग हैं जो studies कर रहे हैं South Asians पे. There is specific to ladies, I think, जो हैं, and they are looking at the specific features, what is the difference between South Asians and others. Let's wait for it. देखते हैं कि उसको उन्होंने compare किया, because they think there is a difference. All right, ये दूसरा केस आ गया. Sorry, we are busy with ourselves. जरा describe करें. ये lab 2 में Rosli and Tariq Shafi हैं. तो can you describe the case? Hello.
Nadeem? Yeah, yes. Nadeem, can you see us?
Yes, we can see the screen and we can see your hands.
All right, okay. I'm privileged to be, to be scrubbing up with Tariq Shafi, whom I know for a long, long time. So with me is Dr. Sajjad Ali and also Dr. Mutahir, and we have, of course, Brigadier Azam guiding us from behind, inshallah. So we have got, can we have the slides on for the patient, please? All right, okay. So we have got a 65-year-old gentleman, diabetic, hypertensive, with inferior STEMI, and who had a primary PCI to the right coronary artery in July of 2021. Now, the presenting symptoms now is that he has angina in CCS class 3 for the last 3 months. Nothing much on a clinical examination, and also creatinine is normal. Next. The echo shows that the LV function is 40%, that's inferior wall hypokinesia. Angiogram shows a true vessel disease, and this is affecting the osteal LED and mid LED and also the osteal circ. Syntax score is 28, the PCI mortality 4 years is 14, and CABG is only 2.9, but he has declined CABG, and this is the reason we're going to do this procedure. Next, can we show the angiogram, please? So if you can see the angiogram, this is the initial angiogram. This is taken from the femoral approach, and what was that? That was a pre, I think. That one you're seeing now is a diagnostic shot. which shows the Osteal LED and also Osteal circ. The circ is quite large, the LED is also quite significantly large, and there is a mid-LED which is more significant in our angiogram this time around. The right is small, non-dominant. We also note that there was an occlusion in the OM branch, but we felt that the most important lesion to be done is really the left LED and Osteal circ and also the mid-LED. Can we come back to the angiogram that we have done today, please? Are you seeing the angiogram now? So what we're doing now is from the femoral approach, that's a 7 French, and this is by BL catheter, but it's very nice. I've not used this before, by Terumo, and sitting very well. And both the lesions were wired. So what you can see now, can we go back? Yes. So clearly the Osteal LED and circ, that's our main lesion. Right after the circ, there's a proximal lesion, but it's only mild disease, not significant. Next.
So Rosalie, Rosalie, can I hold you there? So at this time, what do you think is the culprit? Is that the OM, the culprit for the inferior MI recently?
No. It's CCS class 3, so I believe it must be a fairly large area.
But you said he had an inferior MI. Inferior ST elevation MI?
Inferior MI. That was previously in July of 2021, and PCI was done to the vessel.
Which vessel?
Right. So he had PCI to which vessel? RC is non-dominant.
Right. So what would you like to, how would you like to, the panelists, perhaps you can just discuss and get back to us whilst we prepare.
Yes, I'll ask Bilal, what would you do?
Well, firstly, of course, you'll have to have the 2 wires, soft wires in over here. You don't want to have anything else. Then again, once you have the 2 wires, you get a proper view in, and you may consider either a T stenting over here or something like on another side, because I feel over here you may actually get away with a T stenting or a mini one over there, and that is the one which will probably give you the least metal crumbling over there.
Shahid?
I think DK crush. DK crush. First stents circumflex and then LED to left main and the Duke-kissing.
All right. Asad?
I think probably we should image here first. It looks like a calcified circ, so maybe a strategy to debulk that, or maybe a cutting balloon for both LED and circ osteum, and probably a DK crush.
Sohail?
Yeah, DK crush is certainly the thing of choice. I'd like to look at that OM, that's like a pretty big vessel to me. But how did they work out the mortality of surgery versus angioplasty?
Yes, I had noted that.
And 20, I mean,
yeah,
how come
Rosalie, the mortality was 19% and something on
2% for surgery?
4% for surgery and 19% for surgery on syntax score of 24. Yeah. I don't know.
Yep.
Tanvir?
29, I think.
DK crush, but I'll fix the mid-LED first.
All right. Okay, Mansoor?
You need to fix LED, is important. And then
all right, Rosalie, most of them feel that, bifurcation, Bilal thinks V stenting or T stenting, otherwise DK crush.
All right.
And my only question is, I'm coming back, I'm harboring on this point. He had an inferior MI, and then you said that it's got and RCA looks small. So if he's had an inferior MI and the RCA is blocked off, if it was that small, then it shouldn't have been, I don't know, ballooned or maybe not stented. How do you know that is not the culprit, that large OM? You're going to open the OM, I hope.
No, we did try in the beginning, but we felt that the lesion that needs to be fixed is really the LED and the circ. And angiographically, it looks severe, and it's covering a large area. So we believe that's an important vessel to be done. So,
all right, and there's no perfusion study. No perfusion study. You have any perfusion study? LV is normal, I presume.
No. But seriously, Najeeb, I think for a CCS of 3, when she was, quite well before, and it's the only recent history of 3 months, I believe that must have warranted a much bigger area of myocardium.
Yeah, so that, keeping your argument in front, that is the reason that if you've got class 3 or class 4 angina, then you have to do total revascularization. And in that case, the indication for opening up everything which is relevant, serving more than 5 to 10% of the myocardium is important. And if you look at the AP caudal view, there's a very large bare area, and with retrograde filling of the circumflex, and which is showing the OM, which is a bifurcating vessel. And I think that will keep on causing him a little bit of angina. That's my view. Anyone from the panel?
All right.
Yes. Yes, Colonel Mujib.
Mike, sir, can you come to the
mic? I know, Rosalie, I'm putting you on a back foot, but this is why you are, standing on the hot seat, so you have to answer the questions. Yes.
Before I make a decision, whether it's a DK or T or whatever, I would be interested to know through IVUS the distal mainstem involvement. That will make my judgment clearer.
Colonel Mujib thinks that IVUS is important for distal left main. It looks on this view that the distal left main is involved quite significantly.
That way,
all right. So,
is the least choice.
All right, Rosalie, you carry on.
Yeah. So really, we did what you did, which is we did an IVUS, and we actually assessed and decided. We found that the mid LED is severe. We also found that the osteal LED is significant. There was some lesion. You can see even from the areocranial view that the distal left main is diseased. So that is what we found. But in the body, then it was quite clear. It's very minimal of disease. Now, we also note that the osteal circ, can you play back the osteal circ before this, please? Also is diseased, the spider view. 2 shots behind. Yeah, okay. So this is significant, and we're going to do that, but we're going to stop short at the bump, and we're not going to go across into the proximal circ. Again, we're going to think about the OM much later. Now, we all agree with you that we are going to do a left main stem with a DK crush. All right. So can we just tell you what we did, so that because matter of time, we're going to go up 15 minutes and we're going to show you a step-by-step DK crush.
Yes.
Okay, let's go forward, please. Go forward. So what we did was this is for measurement. Next. This is a 3.0 non-compliant balloon, and it was inflated 12 to about 16 atmospheres. Next. So that was inflated until the osteal LED and into the left main. What is this? Okay. We stented first the mid LED because we want to settle that first before we show you the DK crush. Next. This is a 3.0 by 28 mm. Next. Deployed by about 12 atmospheres. This is to use the measurement, and we think that the next stent should be a it's going to be a 28 mm balloon stent. We then pre-dilated the circ. Next. And that's the results after. Tariq Shafi feels very strongly wanting to use a cutting balloon. We have the only cutting balloon so far, which is 2.75, and this was used. Next. And next. And that's the results after. Next. So he cut the circ first. Next. With a 275, went up to about 15 atmospheres. And next. And next. Once more. And then we went for the LED, another one. I think the result looks better after cutting. Next. Okay, so we also cut the LED, but we went back to wait for you for DK crush. We went to go high pressure in a distal stent, and this was a 3.0 non-compliant, 3.25 non-compliant. Went up to about 19 atmospheres. Next. Okay, so before 2. So here we are. We are going to stand out. From the IVUS, the proximal LED is at least a 4.0. And then left main is a 5.0. And the osteal circ is close to 4 or maybe 4. So what we have done is we are now going to go step by step. We have put in a 4.0 crushing balloon to the LED. And we have got a 3.512. And this is Zines. And this is going to be stented. All right, I think you can push forward a bit more. Okay, this is a 12 mm. All right, that's a bit. All right, I think that's fine there. Okay, go. So a 3-5, we already did cutting. Slowly, 12. What? 12. This is a Zine. Okay, stop. Deflate. Oh, capture that, please. Capture. Let's go back a bit and go high pressure.
4-0 into 12.
No. We'll take high pressure first. We'll take high pressure.
17.
All right, okay, down.
Deflate.
4
or 12, please.
So it depends on how you want to do it. So a number of people would actually want to post-dilate this first and go ahead to high pressure before the stent is being crushed. I think that's fair because this is probably going to use the classical decay crush which is advocated right now. So 4-0 by 12. Okay. So this is an important step because we find that the ones that re-stenose is usually the osteal lesions and especially the circumflex. The more the curve, the higher the chance of re-stenosis. 4-12.
4-12, please.
What is it? 4-12, yes. So now it's a 4-0-12 to the circ. We're going to go high pressure before we crush. Okay.
So how many of you would do the NC before crushing? Because there's one issue problem with it. We'll mention. How many would do who would crush and then recross and then do the NC?
Test, please.
No. He's put the stent in the circumflex. He hasn't crushed it. He's going to use a 4 mm balloon to post-dilate the stent in the circumflex.
15.
Yeah.
16. Recross.
This is the side branch stent.
Yeah.
You can NC the branch or you pull back, give high pressure to fail the osteal and then.
All right.
I'll be out. All right, okay, go.
17. 17.
Okay, this is inflated to about 17 mm. So again, the circumflex is slightly bigger than a 4-0 vessel. Okay, now. All right, so that's the high pressure inflation.
Before we crush, we take the shot before we crush.
All right, close that please. Okay. So we're going to take a small test for you before we crush that stent.
Yes, please.
Okay. Sini. All right. Okay. Looks good. So we're going to pull back a 4-0 by 20 to crush that stent. Okay, capture that. Okay.
Once 190.
So after this, get open 4.50, please. We are going to use a pot brush.
Test, please. Test, please.
And
test, please. Test.
You got to pull back in. Slowly.
Test.
All right, looks good.
5-0.
So we're going to do a pot crush with a 5-0. The vessel in the left main is slightly bigger than 5-0, really.
Recrossing it, just discussing this point, because sometimes I don't do this. I just put a stent, crush it at stent it at high pressure, and then crush it, then you can recross and then use whatever it is. I agree, it's a bit difficult.
After crushing it, you do a step crush or a pot to open the
you can do that.
short the carina so that the
उसका जो part पीछे है उसको आप और वो कर दे. You can do that.
वो करके उसके बगैर तो ठीक नहीं.
क्यों?
You can go behind the struts and
I know.
It's not exposed properly. It just kind of
makes your life easier.
Yeah, the stent goes easier.
You can cross.
I think that's the one thing which makes it
different between OBFW
procedure and this.
Because they are potting with 5 now. They are potting with 5. That will make that.
Because they want to crush it completely, you know.
You're crushing it.
Right. We also have been joined by Dr. Fahim Jafary on the virtual part. So Fahim, welcome. Are you seeing this case and like your comments? We've gone back to the previous lab. No, we come back. Yes, Fahim, welcome.
Assalamu alaikum. Thank you for having me. I'm actually here for the next session, but happy to comment. I agree with what Rosty is doing. We always do a pot crush for most of our cases, and lately we've started dilating the stent deployed before we crush it, with an NC balloon, just to make sure that we open up the ostium of the circumflex as much as we can.
Right.
Obviously, the problem is it's more steps and it costs more because you have to use more balloons. So there are trade-offs in both approaches.
Right, good. Nice to see you. Can we go back on the screen? Yeah, okay. Any other modifications that any of the panelists do in this kind of DKC? Or you're all right with the 11-step, 12-step? Because you can do it in 7 steps.
I think he's taking a step by the book.
Yeah.
These things have to be done by the book. If you don't follow the book, there's no shortcut. Shortcut means suboptimal result and a bad outcome. And in left main, there's no gunjaish for bad outcome.
Okay, Farhan, we can see you on the screen. We've come back on that.
Welcome back. So what we have done in the meantime is that we stented the intermediate branch with the 2.75/23 stent, and we had an excellent result. Then we did an IVUS of the LED stent. The proximal and mid stents were very well dilated. The middle and part of the distal part was underexpanded. So we dilated the distal part of the LED with the 3.0 NC balloon at high pressure, and we had already dilated the middle part of the stent with 3.5 balloon. And in the end, we had an excellent result. As you can see on the screen. Next. This is the NC balloon. Next. 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 So, next. So, that's the final picture. Next. So the left main is looking fine, LED ostium is fine, intermediate is fine, and that's where we stop.
Farhan, आपने IVUS किया, रेमस को भी IVUS किया क्या?
We did not do the second time हमने IVUS नहीं किया रेमस.
ठीक है. नहीं, वो एक डिबेट चल रही थी कि ये बलून जो है रेमस में रखने की ज़रूरत नहीं है और इंजरी होती है, क्या प्रेशर्स हों, तो उसी के लिए just for academic purposes we were just
we inflated the balloon at a low pressure, that was 6 to 8 atmosphere.
Yeah, I
and
agree
then once we do the crossover stenting, we normally balloon the side branch and the kissing inflation. So this is kind of an acceptable inflation, and we know that low pressure inflations do not increase the rate of balloon-induced restenosis.
Yeah, but this is...
retrospectively, do you still think that you needed that balloon in the ramus?
Actually, that gave us confidence that nothing is going to happen to the intermediate branch. Okay. And we went ahead to the LD balloon at very high pressure. We have dilated the proximal LD at a 4.0 balloon with 20 atmosphere.
Because I think operator's comfort is very, very important.
Yeah. All right, so very nice case, and we'll move on to the next level.
Just a quick question for
Bilal, yes.
You had this ramus intermediate, which is 2.5, 3 millimeters wide. If this was a 1.5 thin, long ramus, would you have still put your balloons over there? Because when you have a thin 1.5, the chances of dissection go up.
Yeah, I would just put a wire to keep it open, that's it. It's a small branch in a small area of myocardium at risk.
What I mean is a 1.5 ramus intermediate, which is long and thin, because now it basically means that it is atheromatous plaque running all around. So now what would you like to do?
I think 1.5 vessel I would treat conservatively. I would be very, very keen to save that one.
I think Farhan, very well done, and we'll give you a clap for a very nice case. Thank you very much. We'll move on to the next lab. Let's see what they are doing. This ramus is probably the biggest vessel in this, one of the biggest. It's बहुत बड़ी है, तो इसके लिए important. And I think it's 3.5 at least. बड़ी है. So can we move on to the next lab?
ये traffication.
Okay, so we left you at the point that the crush was done.
Okay. Yeah, we are going to go with the talks now, but let's just quickly move over and see what they finished off the night. Can we go back to the lab or not? Is it finished, the time? I think we'll move on to the next talks.
Oh, next talk. Okay.
उनसे पूछ लें. All right. Rosalie, can you just quickly summarize the case because we are moving on to the talks?
It was not good. So it was crossed and used a 1.5 to open the stent struts up. So now we're going to do the first kissing with a 4040.
So they've opened the struts with a 1.501 and now they're going to go with a 4 millimeter.
It's all right.
Why?
Okay.
I think,
yeah.
I think this is the most important part of the DKC, that you open up.
So
we were talking about leaving struts yesterday and someone was arguing that there's no point in doing. So if that is the case, then if they've pre-dilated that stent with a 4 millimeter balloon initially, then there was no point in doing this step. लेकिन अगर आप जो लास्ट बात हो रही थी कि भाई अगर आप क्रॉस ओवर स्टेंटिंग कर लें और रेमस में कि और वो सर्कमफ्लेक्स इज हेल्दी और अगर कुछ स्ट्रेट्स छोड़ दें नहीं क्रॉस ओवर स्टेंटिंग भाई बात ये थी कि क्रॉस ओवर स्टेंटिंग में अगर आप स्ट्रट को ना भी डायलेट करें सर का हम कह रहे थे कि जी खोल दो तो कोई नुकसान नहीं है हेल्दी सर्क अगर वही थ्योरी पे इस पे लगाएं तो अगर आपने स्टेंट जो सर्क में है उसको क्रश करने से पहले फुली डायलेट कर दिया है 4 से उसका एनसी कर दिया है और फिर आपने ये वाला स्टेंट जो उसके क्रॉस डाला उसको भी ठीक कर दिया है फुली एनसी तो अगर कुछ स्ट्रट्स रह भी रहे हैं अक्रॉस द सर्कमफ्लेक्स तो मैकेनिस्टिकली इट शुडंट मेक अ डिफरेंस वो वही है जैसे क्रॉस ओवर स्टेंट किया ऑप्टिमाइज किया और स्टार्ट छोड़ दिए सर हेल्दी है फ्लो सही है पेन नहीं है छोड़ दो
नदीम इसमें मैकेनिस्टिकली तो एक्यूटली हर एक में फ्लो होता है ना वी आर टॉकिंग अबाउट द लॉन्ग टर्म रीस्टेनोसिस
भाई साहब लॉन्ग टर्म बात ये कर रहा हूँ मैं आप मुझे इसका जवाब दें कि अगर स्ट्रट्स अक्रॉस एक हेल्दी सर्क पड़े हुए हैं क्रॉस ओवर स्टेंटिंग में और उसको आप नहीं करते और कहते हैं कि जी वही रिजल्ट है कि अगर उसको एक छोटे से एक 2 मिलीमीटर या 2.5 से उसको हटा दें सर के
I mean I would always open this side
right so you are
if it's a significant vessel particularly in a young patient as I said earlier if somebody is 80 85 then you may leave him for a year
नहीं वो ठीक है तो उसी पे मैं ये कह रहा हूँ कि इस स्टेप का फिर जरूरत नहीं थी
डीके क्रश में किसमें
जी
डीके क्रश
it's a general
मैं डीके क्रश की बात
you got to do it because the metal struts across with thrombosed you've got to follow the steps and the no shortcut
no I agree I am saying that मैं आपसे कॉमन सेंस की बात पूछ रहा हूँ कि अगर चलिए we'll talk offline we'll talk later अभी ये नुको ये you are opening the strut with a 4 millimeter
इसमें जो आपने बात छेड़ी भी है ना the question actually is that when you have to do it then what are you doing? You may actually be creating a metal load on one side. So that excessive metal load on the two sides that you create by doing it, now that becomes another source of a problem. So the debate always will remain that do you need to do it or not? You never have the answer.
Yeah, because at Coronary you already have more flow turbulence. If you're leaving more struts there without actually making
for the audience what they've done is कि उन्होंने initially जब stent डाला तो उसको पूरा डायलेट कर दिया 4 मिलीमीटर से फुल फ्लेज करके फिर उसको क्रश किया प्रॉपर 5 मिलीमीटर बलून से फिर उन्होंने रिक्रॉस किया पॉट करने के बाद रिक्रॉस किया छोटे बलून से खोला 1 मिलीमीटर से फिर उसको प्रॉपर जो स्टेंट की साइज थी 4 मिलीमीटर बलून से उसका साइड का खोला व्हाइल कीपिंग अ बलून इन द मेन स्टेंट फिर उस स्टेंट को आगे जाके एनसी वगैरह करके फिर बाइफर्केशन पे किसिंग की और फाइनल फिर वो पॉट करेंगे एंड दिस इज ऑल द स्टेप्स दैट दे हैव फॉलो तो अभी वो किस कर रहे हैं तो दे जस्ट लेफ्ट विद वन स्टेप व्हिच इज द पॉट
no problem with the circ balloon this one
so Rosalie can you tell us this is the second this is the pentamulate step or you've done it so you're finishing off with the kissing
okay no we had the first kissing so we made sure that the wire was in the proximal stent struts for the first kissing.
Oh, this is the first kiss.
Once the wire was in, a 1.5 balloon was put up to push to get the stent to open the stent strut, And then we use a 4O, and
Okay,
this 4O is a 4O12.
in interest of time, Rosli, hamara there's a talk by Fahim Jafary from Singapore, so we'll come back after the talk. You carry on, and we'll come and see the final results. So we are heading to the next talk, which is revascularization in stable heart disease. And the patient selection in 2022. And then we're going to have 10 minutes of this talk, Fahim. Welcome. And then we'll have a panel discussion and audience interaction for 5 minutes. So let's go over to Fahim. All right.
So am I okay to share my slides or?
Yes, we can hear you, Fahim. Slide up kar lein, slide share kar lein.
That is why I was hot like just now.
Can you see my slides?
No, we can't see the slides. We can see you. आपके अभी आ जाएगी वो थोड़ा सा.
Achha, so should I?
Yes, now we can see the slides. We can see the slides.
Okay, all right. Right, so thank you very much for the invitation. Nadeem, thank you so much. I am so grateful for the invite to.
Okay, let's have the other way.
I'm very grateful for the invitation to be here. In the next 10 minutes, my job is to talk about revascularization in stable ischemic heart disease and just present an overview of the subject. I don't have any conflicts of interest.
Because we
I'm sorry, are you able to hear me and see me? There's a lot of sound coming in.
Okay. Yeah, we will cross again after that.
Nadeem, can you hear me?
Background noise.
We can hear you very well. So you just carry on.
Okay, sorry. Okay, so
थोड़ा सा echo है वो हम यहाँ से ठीक कराते हैं.
Okay.
Yeah, we can hear you now. You carry on.
Okay,
yes.
Just to start with things, I wear several hats. Of course, primarily I'm an interventional cardiologist, but I'm also a CT and nuclear cardiologist. And so hopefully I'll be able to give you a balanced view of the subject in the next 10 minutes. So now, the ischemia paradigm has sort of for several decades has been used to guide treatment, especially regarding invasive management. And that goes back to data from the 70s, where in the 70s you could see that as you had ischemia in the red, the more ischemia you had, the worse the survival was. And then this was cemented by the Hakamovich group in the early 2000s, where they were able to show that the more ischemia you have, the worse the outcomes are. And at an inflection point of about 10% ischemia, the outcomes of medical therapy in red versus revascularization favored revascularization. And particularly at 20% ischemia, medical therapy was a lot worse than revascularization. And that's what directed our therapy for almost 20 years. But then and so the answer was that ischemia was bad. But as you move forward, there were some limitations of these studies that were quite apparent. The fact that these were observational data, single center data, and a lot of these data were older studies pertaining to a time when medical therapy was neither good nor standardized, and PCI was also in its early stage of evolution. And so when people dared to do randomized trials, the data started emerging that actually in stable disease, revascularization versus medical therapy did not seem to show a difference in death or MI. And while I don't have time to go through all these trials, I want to point your attention to the Courage trial, about 2,000 odd patients, stable disease randomized to PCI with medical therapy versus medical therapy alone, and no difference in any outcome, whether it's death, MI, or hospitalization for acute coronary syndrome. The only difference was revascularization. And there was an initial reduction in symptoms, but at 3 or 5 years, no difference in symptoms either. So actually, patients weren't even feeling a lot better than what they were, whether they got medical therapy or they got PCI. And even at 15-year follow-up, the Courage trial, no difference in hard endpoints. And the fact is that when you look at other trials like the Fahim trial, which is not an ischemia-driven trial, but it used a surrogate of ischemia in the form of FFR, no difference in death, even at 5 years, was between PCI or medical therapy, and only a trend, a non-significant trend in reduction in MI. Of course, the caveats to these trials were that the patients were enrolled after angiography, and so it led to a lot of exclusion of high-risk patients. And if you look at Courage, for example, they excluded patients with low EF, and the really severe cases were excluded. And if you look at it carefully, most of the patients in Courage were single or double vessel disease, and prox LED involvement was only 25%. So they were relatively low risk patients. And so based on this, then the ischemia trial was conceived to answer the question that if you take really high risk patients, what happens to them whether you treat them medically or not? And ischemia took 5,000 patients, randomized them to invasive versus conservative strategy after a blinded screening CT. The CT was to exclude patients with left main disease and to make sure that everybody had some sort of coronary artery disease. In the trial in ischemia, they included much more higher risk patients, moderate to severe ischemia with coronary disease based on a CT, although no left main disease. But they did exclude a lot of patients. For example, those with severe angina, patients with low EF, patients with recent ACS, patients with left main disease, as I alluded to. But in general, a much higher risk population. And if you look at it, 80% had moderate to severe ischemia. LED involvement was in about 87% of the patients. So relatively high risk group, patients who we always thought needed revascularization and could not be treated medically. And what did the data show? At a 3.2-year follow-up, no difference between the conservative arm in blue and the invasive arm in red. No difference in the primary endpoint, death, MI, hospitalization, heart failure, or cardiac arrest. When you look at the secondary outcome of death or MI, you can see that there's an early hazard, more MI in the PCI group, and in longer-term follow-up, less MI in the PCI group. But overall, no difference. And it did not matter what subgroup you looked at, you know, whether they have a lot of ischemia versus less ischemia, whether they have multivessel disease versus single vessel disease, or whether they have prox LED involvement or not, no difference or no benefit of revascularization versus medical therapy. Now, I'd like you to stop here for a moment and just look at this very carefully. We're not saying that ischemia is okay. We're not saying that triple vessel disease is okay. But what we're saying is that when you look at outcomes, whether you have ischemic burden does predict outcomes. Ischemia is bad, especially when you have severe ischemia. It is modestly predictive of MI. And when you have extensive coronary artery disease, it is strongly associated with death or MI. So both ischemia and multivessel disease are bad for prognosis. But the important message from Courage is that no matter how much ischemia you had, or no matter what the extent of coronary artery disease, revascularization as the initial strategy did not alter prognosis. Now, what about symptoms? Well, symptoms definitely had a benefit. The more angina you had, there was a durable benefit in angina. Having said that, the benefit was only in the 21% of patients in the trial who had daily or weekly angina. So if somebody has a lot of anginal symptoms, chest pains, yes, they benefited from revascularization, but the rest, not much of a difference. There was some other exploratory analyses, which I don't have time to look for, but when patients who had mild heart failure or mildly impaired EF, you know, remember the severely impaired EF were excluded, but those with mildly or moderately impaired EF seem to benefit, but those with normal EF, no benefit whether you revascularize or treat medically. And certainly in an exploratory analysis, there was some suggestion that if you achieve complete revascularization versus incomplete, there was a benefit, but that is very exploratory. And so ischemia, an initial strategy had no effect on the primary endpoint of death, MI, or hospitalization, no effect on the secondary endpoint of death or MI, no effect on mortality, an increase in early periprocedural MI balanced by a later reduction in spontaneous MI, and possibly some benefit in those with somewhat impaired EF and somebody who got complete revascularization. But I would consider these as hypothesis generating. It is important to understand that it did not matter how much ischemia you had or how extensive the disease was. The prognosis was different, but revascularization did not benefit. And while there was a reduction in symptoms, for sure, I think it's important to understand that, you know, some of this may well be a placebo effect. We don't know. And we know from the ORBITA trial that whether you do real PCI or sham PCI, actually, in stable disease, a lot of patients benefit, and actually in this trial, there was no difference. Everybody benefited or everybody felt the same, whether you did real PCI or sham PCI. Now, what are the caveats to ischemia? The caveats are, of course, some of it is application to real world. They excluded left main disease, so you need anatomical definition. About 5% of patients were excluded based on the CT. They excluded low EF, they excluded severe angina. And certainly when you look at the NCDR database, about 1 million patients in the US, only about 1/3 meet the ischemia trial characteristics. In other words, 2/3 of patients in a real-world database would not have met inclusion for the ischemia trial. And we know that ischemia-like patients tend to be low risk. If you see in the panel over here, whether you look at death in blue or bleeding in orange, compared to non-ischemia-like patients, the outcomes are a lot better. So ischemia patients were sort of better prognosis inherently. So the selection was weighed toward less severe patients in the ischemia trial, but nonetheless, they had a lot of patients with a lot of disease and a lot of ischemia, much more than we were previously used to treating medically. And the strengths of the ischemia trial were large numbers, randomization before angiography, core lab interpretation of ischemia, included a lot of patients we thought would need PCI, those with moderate to severe ischemia, multivessel disease or LAD disease, and very rigorous adjudication of events. And medical therapy was as good as it could be, and PCI was as good, or revascularization was as good as it could be. So they used state-of-the-art therapy, and the follow-up was more than 90%. So how do we put this all together? I will take you to a bunch of patients in your practice who have chest pain, and when you look at them with a history, certainly a certain number will have accelerating symptoms that are getting worse, and they clearly need to go to the cath lab, and you would send them to the cath lab for sure. What about the rest? Well, some of them you will consider stress testing, and when you do a stress test, you will find those with either normal scan who kind of need to then could be treated medically, and there will be those with a really, really positive stress test. I'm talking about blood pressure dropping, ST segments going up, those kind of scenario, and certainly those would be referred to the cath lab. But before ischemia, the rest, those with moderate to severe ischemia, would be referred to the cath lab. But after ischemia, I think there is some degree of equipoise between medical therapy and invasive. And in this group, you would then like to have a discussion with the patient about options. And one option would be to talk to them about excluding left main disease, which you need to exclude. And of course, some patients will say, no, I want to be sure, and they would go to the cath lab based on patient's wishes. But then for the others, you may rule out left main disease, possibly by a CT, to prevent missing patients like these. This is somebody in our practice, infralateral ischemia, was referred for a CT and ended up getting lost during the COVID time. And when he came back 6 months later with an ACS, he had critical left main and multivessel disease. And sure enough, those with left main disease would be then referred to the cath lab, but then the rest you could treat medically. And when you treat them medically, some of them will fail medical therapy and you would then refer them to the cath lab. But then the majority of patients you can see will be treatable with medical therapy. And that's the important point I want to make. And I just draw your attention to this paper, which just points out why is it different between stable disease and ACS? What does ischemia mean in each of these different things? In stable disease, ischemia essentially, while it identifies ischemia-producing lesions, the prognosis or the long-term risk is related to the mild plaques that with time present as ACS. And so the risk in the ischemia reflects the atherosclerotic burden. However, in ACS, ischemia actually reflects the biology of the unstable plaque, which if you don't treat, may end up causing an infarct. And so in this ACS, the treatment is still to stent the culprit vessel, but the long-term risk still remains with the mild plaques that may progress with time. And so to conclude, ladies and gentlemen, the ischemia paradigm, in my view, has changed in the sense that detection of ischemia in stable disease still remains an important step because it identifies patients with atherosclerosis who will then be eligible for appropriate medical therapy. Treatment of ischemia, on the other hand, in stable disease by revascularization provides a durable symptom benefit in those with symptoms, with a lot of angina. But it provides no clear prognostic benefit with some caveats, the caveat being that the highest risk ischemia patients were excluded, and left main disease was excluded in the trial, and low EF was excluded in the trial. I would also say that in 2021, medical therapy for ischemia is okay as an initial step. Remember, as an initial step. If prognosis is the concern, it is okay. The caveats being that they don't have severe symptoms, they're not having an ACS, they don't have heart failure, they don't have low EF. But in 2021, rather 2022, revascularization with ischemia is also okay as an initial step if the symptoms are compelling. So it is okay to also treat them with revascularization, but you have to understand that it will not affect prognosis, but it is okay to make patients feel better. It comes down then to having a discussion with the patient. And so we should, I think, have the courage to embrace the ischemia and be comfortable treating ischemia medically. But at the same time, as an interventional cardiologist, we should not be discouraged to stent once you've had a proper discussion with the patient. And so the proper discussion is that in stable disease, it will not make you live longer, but it may make you feel better, and you will still have to take tablets. You don't get away from tablets. So finally, in 21, revascularization should be, or 22 rather, revascularization should be the initial choice for acute coronary syndrome. We don't advocate treating ACS medically. And one final sobering thought that whether you look at courage or whether you look at ischemia, at 5 years, the event rate is nearly 20%. So we still have a very long way to go. Ladies and gentlemen, thank you very much. I apologize for going over my time.
Thank you, Fahim. This is Bilal Mohyudin. How are you doing?
So
in short, what you have said is, we are as confused as we were yesterday. This doesn't make any sense. Probably the whole thing is, कि लड़का बहुत अच्छा है लेकिन प्याज खाता है. So that's the whole story that goes. So if there are any comments?
Yeah, I mean, fair enough. I mean, ischemia trial is very impressive and I really follow it. How do you follow these patients? If you want to redo the stress testing, or, is it annual, biannual, or 5 years?
I personally actually will follow them clinically most of the time because, again, if the stress test shows ischemia, you're still back to the same, you're back to the same boat. They have ischemia, what do you do? So as long as they're doing okay symptom-wise, I'm usually not worried. I will periodically check their EF every couple of years. If the EF still stays normal, I think it is okay. Of course, there are variations to this. Every patient is individual. And so it is while it's okay to do stress testing, routine stress testing isn't necessarily going to change your approach for a lot of these patients.
So talking from a quality of life point of view, these stable ischemic heart disease patients, so would you allow them to go for a mountain climbing? That they can become ACS over there?
Yeah, so that's a good point. I think that, so assuming that most patients are not marathon runners, athletes, mountain hikers, for most patients, this approach, I think, works perfectly well. And I think it is okay. For individuals, medicine, fortunately, is not, cookie cutter, is not regimental. So for those kind of patients where you are really worried that could they have an ischemia-induced event when they're somewhere, on Mount K2, different story. And I think then, again, it comes down to shared decision-making with the patient. But you have to be upfront and say, okay, it may not save your life, but these are potential benefits, and you're going to be stuck somewhere on, at 8,000, miles up in the...
These are all very good things, but let's say from another angle, it's a patient has got atrial fibrillation and is a 75-year-old gentleman and has got Parkinson. You probably would say, of course, this person should not be on the NOACs now. But if the nurse does not have Parkinson, you say, okay, may have it, but then slips in the washroom, hits his head, and ends up with a major subdural. So these issues of medicine will always remain. You will always have these catch-22 situations. And that is where actually the stable ischemic heart disease and the ACS, actually since they bounce between each other, we always keep getting into that bungle. Your patient comes in, walks out of your clinic, knowing that everything is good, feels happy, does those foolish things, and next thing you know, he ends up with problems.
What ischemia has done is made it, quite okay to treat these patients medically as an initial step until you find that something has changed or a patient's own decision-making prompts you to revascularize. It doesn't mean revascularization is bad. What it just says is that there is no prognostic benefit and there is a symptomatic benefit in those with a lot of anginal symptoms to begin with, which is not every patient. It is some patients, not all of them.
So what I'm saying is that we are as wise as we were yesterday. Nothing new has been added as far as that is concerned.
I think that we are a lot wiser, I think. Yeah.
If I could respond, I think it's not fair to say that we're as confused as we were confused yesterday or 10 years ago. I think we got more data. We know now that the medications are very effective. They're much more effective than they were years ago. And
the medicines.
Yes.
Better medicines.
The medications are much better, and they're really effective. And even if you do a surgery or angioplasty, you're going to have to continue the medication because disease is progressive and you have to go on with it. And so if you've got symptoms which are easily controllable, wonderful, carry on. And if you think the symptoms are there, and it's very critical, like I doubt if you have class 1 and 2 angina and you got proximal LED, you got to say carry on medication. And the only thing which I look at these two trials, they're both done with great, very experienced physicians. Okay. And one of them had a great CT scanner. So you do a CT scan on everybody and you exclude those 3 vessels and left mains, and then you take it on from there. So, you know, that's the only thing which I take
Fahim, do guide me. Does it mean that we should be training all our fellows mostly in doing left mains?
So regarding that, this left main bit, I think before we go into the further discussion, may I request Dr. Tanvir Rab to kindly come up and let us all go through the left main and multivessels, and then we'll have the final discussion after that.
So just while he's coming up, just a question. This is Asad here, Dr. Jafary, excellent talk. Just a question. You know that whenever we discuss ischemia, we miss out on the 20% or so patients who actually required an angio because they had symptoms despite medical therapy. And I think another 20% of the ones who got the angio required revascularization. So I think if symptoms are changing, even ischemia trial sort of weighs in on revasc.
I agree. So ischemia talks about medical therapy as an initial strategy. We're not saying, you know, you're medical and nothing else forever. It is what is the initial step, and I think it is the emphasis is that it is okay to treat patients medically, and we need to be comfortable with that. I'm saying this as an interventionalist because I think that patients do okay with medical therapy in many, many instances as long as they don't have left main disease.
Perfect. Yeah.
Assalamu alaikum. Thank you, Bashir, for inviting me to this wonderful program. I first came to an interventional meeting in Karachi about 12 years ago, and this has matured, and it really is a very good meeting. So I'm going to talk to you about, more slides, please. Okay, so we're going to talk about left main and multivessel coronary heart disease, CABG versus PCI. So this is a segue from what Fahim just discussed. So I'm going to talk to you about the 2021 ACCHA SKY guideline for coronary artery revascularization, because all what we've talked about or you've heard now goes into guidelines. So what do they do with professors like me? They put them on guideline committees, and my role on this particular document was to edit it, review it, and reformat and put it all together as part of the guideline group. And the next project is ACS. So that's what I do for this committee. So the important thing is that when you take a patient, you have to see what is the risk of death with CABG, for example. And in patients who are considered for CABG, the STS score and the syntax score must be calculated. So this is the next guideline. It says that in patients with multivessel CAD, calculating the syntax score really identifies the therapies you should take and what the outcome would be depending on the complexity of coronary heart disease. And it gives you a class 2B recommendation. Just to remind people, a class 1 recommendation is everybody agrees on, it comes through strong trials, you must do it, you should do it. On the other hand, class 3 is a no-no, you shouldn't be doing that. Class 2A comes from the weight of a lot of documents, we call it level of evidence, and class 2B comes from smaller trials or anecdotal trials. For example, melvactam and hypertrophic cardiomyopathy would probably come to a 2B class. So the important thing is, why do we revascularize people? To improve symptoms. So if you don't have symptoms, we do not know if medical therapy may be good enough, but you revascularize people who are having symptoms. So in patients with refractory angina, despite medical therapy, with significant coronary heart disease, it's a class 1 indication to do a revascularization procedure. If people have no symptoms, leave them alone, class 3. So let's go to the left main disease, for example. This is the best evidence that's put forward in this document. So remember, the outcomes of left main disease was compared to medical therapy. There was no PCI available at that time. So the first VA cooperative study that came out showed a significant benefit in patients who had left main disease in terms of survival versus medical therapy. So we know that. CABG is very useful. Then if you looked at it longitudinally over many, many years, for example, 10 to 12 years, it showed that the CABG arm stayed stable for left main disease, but in the medical therapy arm, which is below, you had decreased survival. So you know bypass surgery works. And if you look at the extension of survival for about many, many years, the best benefit, best bang for the buck is patients with left main disease, followed by patients with abnormal LV function who have the best benefit from surgery. Let's look at left main stenting, for example. There's a lot of data out there. First of all, the main clinical trials, the syntax left main, pre-combat, Excel, and Noble. And the general thing was at 5 years, mortality for the intermediate and low syntax score was very comparable between the two groups. So the death rates were very, very low. So left main PCI or CABG, PCI versus CABG, the death rate is very low. And 10 years again, and again in 5 years, except for Excel, most of the studies show that again, death, all-cause death was equivalent in both groups. Now, if you go on to 10 years now, 10 years mortality was very similar, again for CABG and PCI, and again, very similar for pre-combat. So based on this data, you can conclude that left main PCI is acceptable to CABG, which is the gold standard, and PCI with drug-eluting stents, not bare metal stents, but new drug-eluting stents versus CABG shows comparable safety and outcomes for patients with low to intermediate complexity or syntax less than 32. However, repeat revascularization is more common after PCI. So importantly, the guidelines committee wants you to have a heart team approach. So if you have somebody with left main disease or complex three vessel disease, you should consult a surgeon, and basically PCI has advantages of less invasive, fewer procedure complications, lower MACE, and rapid recovery, where CABG is more durable, particularly if a LEMA to LED is used, fewer adverse events after 1 year, and repeat vascularization is very low. But there's no difference in terms of long-term survival outcomes. So the heart team approach is a class 1 recommendation. And this, I'll skip this cartoon, but for the unprotected left main, osteal and shaft actually is very simple to do, and these should be stented rather than referred to surgery. For the patient with distal left main stenosis, which is the majority, you should calculate a syntax score, look at the heart team, and discuss whether CABG or PCI is an option with the patients. And for the surgically ineligible patient, PCI is always an option, but for left main, it's very strongly recommended that you follow proper techniques, for example, DK crush. Don't deviate from the standardized techniques. So before 2009, all the guidelines said CABG class 1, PCI class 3 for left main. Now, in the new revascularization guidelines, we've made a class 2A. So what about in patients with, to improve survival in left main with stable ischemic heart disease? Class 1 CABG is still a class 1, PCI is class 2A. And so if you look at the box that says that if you look at patients with left main stenosis, you go through the algorithm and say, well, if the disease is complex, CABG, disease is not complex, you get a PCI arm. Now let's go to multivessel coronary disease. We just discussed it. So what has happened is there's no real major trials that say CABG or PCI is superior in multivessel coronary disease in stable ischemic heart disease patients. Both Courage showed that, both ischemia showed that it was not superior. So what the surgeons got upset about was we downgraded from class 1 to class 2B, a recommendation, class 2B for both PCI or CABG with stable ischemic heart disease when patients who have multivessel CAD. So what is the data? So if you look at it, the main thing for revascularization in stable ischemic heart disease is to reduce cardiovascular events. So in patients with stable ischemic heart disease, with multivessel coronary disease, either CABG or PCI is appropriate to reduce the risk of future cardiovascular events. So if you look at this, if you look at the evidence of coronary artery bypass, graft surgery, and survival, if you look at the 10-year view from the studies that I just showed you, at 10 years, there were really the major advances in versus medical therapy was in the patient with left main or triple vessel disease versus medical therapy. But now we're trying to compare CABG with PCI. So if you again look at CABG versus medical therapy, CABG on the top, medical therapy below, surgery had an advantage for everything, particularly but in left main stenosis. And left main stenosis or proximal LED stenosis, surgery had a huge advantage. So let's go back, okay. So let's go to the ischemia trial. At 5 years, this ischemia trial now starts crossing over, and this is up, and that's in B and D. You can see that the patient who had conservative management had more deaths after 5 years versus those who had revascularization. So the new class 2 recommendation recommends a downgrade from class 1 for CABG, because most old trials was CABG versus medical therapy. There's no comparable with PCI. So basically, now our conclusion is CABG versus PCI for stable ischemic heart disease patients with multivessel disease of low and intermediate complexity or syntax score less than 32. So that's where syntax score is very important. So if you look at the syntax trials at 10 years, what favors PCI is generally a low syntax score. What favors CABG is a syntax score above 32. So, and then again, with the 10-year survival after bypass and the extended survival, syntax study again showed the advantage of low syntax score in blue and high syntax score. So low syntax score, PCI is equivalent to CABG mortality, equivalent in outcomes, but revascularization is higher in PCI. In high syntax score, the mortality is greater with PCI and revascularization too, and therefore surgery is favored for syntax more than 32. So in patients with complex disease who need revascularization for significant left main with high complexity, is recommended to choose CABG over PCI to improve survival in the left main group. However, in patients who require revascularization multivessel disease with complex or diffuse disease or syntax greater than 33, it is reasonable to choose CABG over PCI. So what about low EF? So if patients have stable ischemic heart disease and multivessel disease with severe LV dysfunction, EF less than 35%, CABG is recommended to improve survival. In patients with ischemic heart disease, multivessel disease, appropriate for CABG with moderate LV dysfunction, which is 35-50%, CABG in left ventricular mammary artery graft is preferred. What about the STITCH trial? STITCH trial was mostly a heart failure trial, but after many, many years, there was a divergence that patients who underwent CABG had more survival than those who underwent medical therapy. And again, the rates of hospitalization were reduced in patients with LV dysfunction who underwent surgery. The rate of rehospitalization reduced in patients with heart failure. So let's cross over. What about diabetes? A big group. In patients with diabetes and multivessel disease with involvement of the LAD who are appropriate candidates for CABG, CABG with Lima to LAD graft is superior to any other form of therapy, particularly PCI. Then the class 2A is patients with diabetes and multivessel disease who are amenable to PCI and a poor candidate for surgery. You can still do a PCI in that group. In class 2B, in patients with diabetes with left main disease and low to intermediate syntax score, PCI may be considered as an alternative to CABG, but for diabetics, particularly diabetics with low EF, CABG with Lima to LAD is superior to any other therapy, particularly PCI or medical therapy. And that came from the FREEDOM trial. So diabetes is a very strange disease. At 8 years, if you underwent PCI, your mortality was 24.3%, with PCI versus 18.3% CABG, and other things like MI, stroke, and revascularization in all groups of syntax, low, intermediate, high. In diabetics, they did worse. Okay, what about revascularization to improve survival in stable ischemic heart disease with normal function with or without proximal LAD stenosis? So in patients with stable ischemic heart disease, normal LV function, and significant stenosis of the proximal LAD, the usefulness of coronary revascularization is uncertain. So that's a new thing, that if you have stable disease, even if you have proximal LAD disease, and that came from the COURAGE trial, we're not sure whether bypass is necessary. What about physiology? In patients with angina or angina equivalent, for example, and angiographically intermediate stenosis, use of FFR may help in decision making. And if the FFR is negative, you don't need to do anything. However, in FAME3, which is just published, that in patients who had FFR-guided PCI did not have an advantage over routine 3-vessel bypass surgery. So we're unsure about the FFR-directed multivessel PCI compared to CABG. So in conclusions, PCI really does not reduce mortality. In older trials, outcomes of CABG are compared to medical therapy, and modern medical therapy is not available, such as P2Y12 inhibitors, ACE, ARB, or statins. CABG has the survival advantage of left main stenosis with increased death rates in the medically treated group. There's no survival advantage of CABG over PCI and stable ischemic heart disease, including left main stenosis, and low to intermediate syntax score for multivessel disease. And finally, Lima to LAD graft has survival advantage, particularly in diabetics and those with low EF. And thank you for your attention.
Just a comment, in the Excel trial, the aim was PCI in low to intermediate score, but when the CDs were reviewed in the core lab, a quarter of them were in the higher syntax group.
That's correct.
Basically, syntax actually did an all-comers for a trial.
Yeah. So in that particular group, particularly syntax and noble, Excel and noble, syntax did not really influence your outcomes. Let's put it this way. But if you look at all the other trials, it's very clear low to intermediate syntax can do equitably with PCR CABG. Excel was an outlier.
And if you look at the Syntex trial, 10-year follow-up, the Syntex score had a different outcome for different levels in 3 vessels, but in left main, the outcome was the same.
That's correct.
In Syntex and left main.
That's correct. Yeah. Pure left main.
Pure left main.
Yeah. So a lot of these studies and things that you are talking about, the Q-lot, the DK crush, etc., these are all high Syntex score patients. These are those set of patients.
No, isolated left main.
No. Then you've got
the technique, technique, nobody has really compared techniques because that's apples to oranges.
Yeah.
But isolated left main is actually a low syntax score.
Yeah, isolated left main and then the body is a low syntax. But when you have got a distal left main and an LAD and a circumflex,
multivessel disease.
Now you've got a multivessel disease going on, and you have got these syntax scores. The cases that we are actually sharing with all our fellows over here, these are all high-risk cases on syntax. So as far as from a syntax point of view, already it has been defined that these are CABG relevant. So from an ethical point of view, when a doctor turns around and says that, okay, I will go ahead and do a PCI, of course the patient may have been counseled adequately, etc. But once the literature is also saying that at the moment, we are not going to be producing anything better. In fact, with some trials it is showing that it actually worsens out the situation. So what is your take on that?
So first of all, procedurally, these procedures have low mortality on the table, okay? So the procedure does not kill the patients, the long-term outcomes. So procedures are safe, okay? Whichever technique is used, if we follow that. And clearly, the guidelines committee looks at it and says, this is data that the higher syntax score will have poor long-term outcome, particularly repeat revascularization. But again, if you have normal EF and you're not a diabetic, your mortality will still be very similar to CABG, you know what I mean? So as simple as that.
So the CABG becomes the cutoff, basically.
The CABG becomes
the diabetes becomes the cutoff.
Diabetic and low EF.
Yeah. Just a little comment, Tanvir. I enjoyed your talk since it is coming out of Emory.
No, it's coming out of the ACCHA.
No, what I mean is, I know you were involved in East study before the turn of the century. And you can look into this new subset while you peep back into
East.
Surgery versus PCI in the early days.
But those are balloon PCI, there's no drug stents available.
I know. That's what I mean.
Those
were the early days. When you used to look into surgery versus balloon. And now, with all the new equipments, new guidelines, we are much wiser. How do we compare, both procedures for different subsets?
Absolutely.
It is interesting.
But again, the important thing, at least in America, they want patient involvement in the decision making. Look, this is the data, okay? And what do you want? So patients are a very important part of what procedure he wants,
Absolutely.
It seems that we have already overshot our time, and Professor Rosley has also moved on and finished his case, so I'm sure when he'll be joining us over here, we can discuss it with him. With this, I will say thank you to all the panelists for taking out their time, and to myself also, thank you for coming over here, and to Bashir Hanif and Noman over here for putting up such a lovely show. All the best for the rest of the conference.
Anji, for the next session on acute coronary syndrome interventions, it's a joint session of PSIC and Asia Pacific Society. I would request all the other chairpersons to join us on the stage. Professor Tanvir Rab Sahab, I believe you're supposed to stay here. If you can. Professor Abdul Samad Sahab, Professor Feroz Maiman, Professor Saqib Shafi, Professor Farooq Jalisi, Professor Shahid Hamid, and Professor Shahbaz Qureshi Sahab. Please come and join us on the stage as panelists. And I believe we have the speakers already online and waiting. So Dr. Mirwat Al-Asnaq from Saudi Arabia, she's already, so can we get her online? And meanwhile also we have online panelists, past president of the ACC, Dr. Dipti Echipuria, Dr. Ahmad Shaiban, Professor Singh Woon Ra from Korea, and Dr. Naeem Tahir Kheli, Dr. Atif Bashir, Dr. Rosli Ali, I believe he'll be joining us from AFIC, and So the talk is going to be on patient with ACS and 3-vessel coronary disease. It's a dilemma we all face. We fix the culprit lesion, and then what to do about the non-culprit lesions and in our practice. So I think we'll get a good insight from Dr. Mirwat Alisnag on that. Can we get the talk playing?
Good afternoon, everybody, and thank you for this kind invitation. I'm going to be sharing a case with you today that, we do see these kind of cases in practice not infrequently. Unfortunately, the data has been being shaped over the last few years, but there are still those patients that kind of fall in the in-between, and it's a little bit difficult to figure out what we're going to do with them. So I'll share one of those cases, and definitely happy to be here with the immediate past president of SCHI as well, Tim Henry, and we'll hear some insights from him, and of course the AFIC community as well. So this was a 69-year-old gentleman. He's diabetic, hypertensive, hyperlipidemic, ex-smoker. His comorbidities were quite significant. He had obstructive pulmonary disease, chronic obstructive pulmonary disease, a prior stroke with some residual deficit. Nevertheless, he was still independent and did have advanced peripheral vascular disease and underwent below-the-knee peripheral work. He presented to our hospital with an acute coronary syndrome, and initially his EKG did not really show any changes, but within the first hour, there was significant evolution of his EKG, and so to speak, he was infarcting under our noses. And this was the EKG approximately 1 hour after presentation to the ER. His echocardiogram, this is what the echo showed. The LV was certainly dilated. There were significant wall motion abnormalities, and this was a quick POCUS that we opted to do as we were calling in the cath lab, and you can clearly see the anterior wall and anteroseptal wall are akinetic, nevertheless preserved thickness. Now, during the course of this time, his systolic blood pressure was 90. His cardiac index, when we took him immediately to the cath lab and started to get some hemodynamics, cardiac index was 1.9, LV-EDP was 19, and his initial lactate that we got from his blood gases was 1.9. Unfortunately, the SCHI definition of shock evolved as well and is sort of guiding us patients who are extremists and all the way from those who are just at risk. And you can see that there are a lot of patients who have quote-unquote impending shock or early stages of shock, but don't quite fall into the definition of shock. And this was his angiogram. We opted to go ahead and put in an impella, as you can see. Left main was okay. Circumflex had bifurcation disease of the circ and the obtuse marginal branch, and the LAD itself was 100% occluded. So we went ahead and did what we need to do. We put a wire across, wired it, ballooned it, stented the vessel, and this is what we ended up with after ballooning. With the circulatory support, we were able to administer a lot of intracoronary drugs in order to improve distal bed flow, and then we went ahead and stented it and did the appropriate post-dilatation, and this was the final result of the LAD. So at this point in time, the patient is stable, and the question is, what do we do about complete revascularization? I think what we opted to do is we have mechanical circulatory support. The data recommends complete revascularization, and so we went ahead and figured we're going to tackle a bifurcation. We may as well do it while we have mechanical support in this patient. Was this the right decision? I don't really know at this point in time because, again, this patient kind of falls in the in-between. So we went ahead and, dilated and stented the main vessel. We had a wire in the side branch as well. We always maintain access into the side branch. Went ahead and did proximal optimization, recrossed, opened up the struts, did kissing inflations, and then opted to go ahead and stent the side branch, do kissing inflation again, proximal optimization again, or POT. And then this is the final result that we ended up with in the circumflex as well as the LAD. And you can see it, the final image here in iliocaudal. So I think the questions that we have are really, when we look at the complete study, patients with STEMI and multivessel coronary disease, complete revascularization is superior to the culprit lesion only. in reducing cardiovascular death, myocardial infarctions, as well as a risk of future myocardial infarction and ischemia-driven revascularization. When we look at the culprit shock, however, patients with an acute MI and cardiogenic shock, the risk of death and renal replacement therapy at 30 days was actually lower in the culprit lesion only PCI than with immediate multivessel PCI. So not exactly what we did with this patient, and there was no real mortality difference between the two groups at 1 year of follow-up. The only caveat is that, when we look at the culprit shock, they took patients who had established shock. And it's very difficult to go back retrospectively and inspect the data and try to apply the SKY definitions to these patients and see who are the patients that in fact would benefit from culprit lesion only as opposed to staged complete revascularization, and where our patient falls here. Clearly his hemodynamics were suggestive that this was early shock, and he did evolve in our emergency room, so our threshold to be very aggressive up front was very high for this particular patient. And sadly, a lot of the data that we have that are actually looking into high-risk PCIs and mechanical circulatory support is lacking. This is data from a British registry that actually looked at independent predictors for patients with last remaining vessel. Now, this was not really a last remaining vessel patient, but of course it does take into consideration not only the patient's presentation and cardiovascular risk factors, for example, diabetic patients and so on, like our patient, peripheral vascular disease like this patient, severe LV dysfunction, again like this patient, but also looking at what kind of therapy we need to offer. So are we going to require, is this patient cardiogenic shock and so on, but are we going to require rotablation, laser therapy, mechanical support, bifurcation stenting, etc.? All of these clearly increase the incidence of adverse events and worse outcomes in patients. Support. And the same group looked at mechanical support in PCI in the last remaining vessel as opposed to mechanical support in all remaining PCI procedures. And you clearly see that mechanical support was used a lot more when it was the last remaining vessel. And you see that, sometime between 2009 and 2012, there was a slight increase, and then they started to decrease again in terms of utility. And I don't know if it's because they were starting to pre-select patients, whether some of the data that was coming out on balloon pumps, for example, and so on, showing no significant benefit. And so they started to taper down their use. Again, this is registry really data, and you really cannot look back at it and look at events. But what we do see is that when you do PCI in these patients, their in-hospital mortality, 30-day, 1 year, and in-hospital major adverse cardiovascular events were clearly much higher than other PCIs than when you're doing it in these kind of patients. And so last remaining vessels are a small percent of the total PCIs that we do perform. In this particular study, it was looking at England and Wales, but if we look at registry data from the US and globally, it falls around the same track. And clearly higher risk than usual PCI, evidenced by the fact that 12% died during the same hospital admission and 24% at 1 year follow-up. And so really when we're looking at these kinds of patients, we do need to make sure we create room for optimizing guideline-directed medical therapy. We do need a heart team decision to discuss clear risks and benefits of doing a complete revascularization on the spot, deferring it, or doing the culprit and then referring it to the CABGers and seeing what they want. But I would also add to that, trying to be as minimalistic as possible in order to allow the patient to recover, factoring in operator experience as well and volumes. And so, really taking into consideration, do I want to do in this kind of a setting a provisional stepwise bifurcation, for example, as opposed to a 2-stent strategy up front? The role of intracoronary imaging, IVUS or OCT, provided that the kidney function is permissive. And of course, the anticipating complications and adverse events early, meaning that you want to have your anesthetist on board, mechanical ventilation on standby, etc., should you need it, mechanical support, of course. And so I think I'll stop here and open it to discussion with the rest of the faculty. Thank you for allowing me to share my case.
Excellent talk. And we have 5 minutes for discussion. I'll request Dr. Jalal, Dr. Hikmatullah, and please come to the stage. And Dr. Tariq Abbas, please. So any comments from the panelists, and also our online panelists please, any comments regarding the talk? And this is quite a hot debated topic, in terms of issues, whether in a sick patient, the case that you presented, it's a little against, I guess, the norm with the guidelines now, that if somebody's in shock, should you be attempting a bifurcation lesion after you've done the culprit? So it's a class 3, and I know you have Impella there, and you have I guess, the safety net. But ideally, looking from guidelines perspective, you probably want to stage the CERC bifurcation lesion later on. So your thoughts on that?
Yes, Naman, obviously, it's a nicely done case. Someone with acute STEMI and requiring hemodynamic support, complete revascularization done. But I don't know in our setup where fellows and residents are doing it in the middle of the night. We should advise doing complete revascularization in this kind of a patient. Maybe do just LAD, come back, do it a couple of days later.
Generally, I guess most of the data is for stage PCI. Very few trials actually did it ad hoc during the same setting. Is it true from the panelists? Any thoughts on that? I just
wanted to ask Dr. Sahiba that in patients who have cardiogenic shock and they are undergoing revascularization, what would be the mechanical circulatory support which would be recommended, number one? And if the MCS is not available somewhere, what inotropic support?
What is not available, I'm sorry?
When the mechanical circulatory support is not available, then what would be the inotropic support that would be possible and would help in these patients? And in patients who have cardiogenic shock, they already have a very high mortality, 50% still die. And if you do only the culprit vessel PCI and not do anything to the other vessels, perhaps the mortality would be higher in these patients.
Yeah, I mean, revascularization does bring it down from like 80-85% to 50%, but they still have high mortality. Dr. Lesnak, on your thoughts on what is the best mechanical circulatory support, and if it is not available, what is your inotrope of choice and depressive support of choice?
So I'll answer this very quickly and briefly, and then perhaps we can engage Dr. Henry, who's with us as a panelist from the US, because that's clearly his forte and area of expertise. The reason I presented this case is that this is a patient who had impending shock or early shock. So by definition, he did not fall into the higher criteria. And I think it was an elective decision to go ahead and put the mechanical support. And this is not the typical case that fit into the culprit shock trial. And even in the culprit shock trial, there was a significant amount of crossover, and there were some who had it staged, complete revascularization, and some even had it in the same setting. So to answer your question, that use the mechanical support that you have and that you're comfortable with. And there's no harm in areas where you do not have a shock team or a shock center to transfer to a higher center that does have mechanical support. Because as I showed, this is a patient who came in with no EKG changes, and within an hour did change and ended up with ST elevations under our noses. And so I do think that anybody with borderline hemodynamics really should be transferred immediately when they're still stable enough for transfer, because it gets very difficult when they're profoundly shocked.
Just a comment over here.
We have past president of SCAI, Dr. Timothy Henry, with us as well. Your thoughts on this case?
Everybody, can you hear me okay?
Thank you for joining us. Yes, we can hear you.
Yeah, so I think it's a terrific case because it really points out, it illustrates some things that we know, and then really brings into question things that we don't know. And this will be part of the talk as I go forward. So Mirvat, you did that perfect. You set it up perfect.
So I guess.
Can you hear me okay?
Yes, we can. We can.
Yeah, so I think here's the point. I would have called this patient stage B. So I would have not said not in cardiogenic shock to start with. And I think whether to fix the other culprit, I think complete revascularization is clearly indicated, but the question is the timing. And I think what's more controversial, should you use a mechanical support in this trial or not? We don't have evidence, yes or no, but we really haven't tested it clearly. And so I think what we have to do now with acute MI, we've come a long ways in terms of revascularization and outcomes. And the issue about multivessel disease remains one of our areas of further investigation. 10 years ago, we felt that never do the culprit artery. It was class 3 to do the culprit artery. We now know that complete revascularization is better, but I think the timing is what takes judgment. And it depends. Is it in 2 o'clock in the morning? What's the renal failure? How large is the risk territory? All those things need to be taken into account.
Absolutely. So I think with that, we'll get started with your talk as well. And can we have his slides? You had some comments, Dr. Atish?
Yeah, I had a few comments. First, this patient
While the slides are being put up.
Yeah, so my understanding of the case was this patient did not present with a ST elevation MI.
Can you, Dr. Timothy,
and there was
share
an
the
hour
slides?
lap between the EKG changes.
Yeah, some of them do trying that.
So I think two comments. Number one, what was the initial EKG? How was he treated in that hour? And the second thing was, I think there was some comment about transferring this patient once he goes into shock. I don't think that's appropriate when you have a new ST elevation evolving in your ER. I think you should try and do the best, whether you have mechanical support or not. I think the best treatment would be with that echo, with the anterior wall not moving, you're pretty confident it's the LAD. Go after it, help the best you can. If you don't impella, if you don't have a balloon pump, doesn't matter, just help them.
I guess the transfer would be after opening the LAD and getting the balloon pump. If you don't have that, then you put them on support and then transfer if they're not improving for a center which can do an LVAD or a transplant. But otherwise, the key is to open the LAD up and an anterior wall MI, you would not be absolutely.
And the big thing
so I think we have the slides
to critique
ready.
is what treatment was given in that first hour when he was not having the STEMI in the ER. And I think that's critical, that medical therapy.
Yeah,
when they show
absolutely.
Up with
You
ACS.
should initiate therapy right away before, absolutely. The standard ACS protocol. So with that, we'll have what we need to do in STEMI for 2022. So Dr. Timothy Henry, the stage is yours, please.
Yes, so my goal this morning is to talk a little bit about where are we with STEMI in 2022, and then to really focus on what we don't know or what we need to know. So hopefully, can you see my slides?
Yes, we can.
Hold on 1 second.
We can see your slides.
All right, there. So I think this is the challenge with STEMI is we have acute plaque rupture, and we know now that the solution, what I call 1 hour artery cleaners or primary PCI, has clearly been shown to be the most effective. And doing this with acute regional STEMI systems have made a dramatic improvement in outcomes across the world. This is data from the United States. It shows that over time you had increase in primary PCI, as you see in the black dots. As associated in red, you see a significant reduction in mortality. The other thing that's happened in the United States is there's been actually a decrease in the incidence of STEMI. In contrast, and I put this slide up because many parts of the world, this is when we were in Malaysia a few years ago helping to set up a STEMI system across the country, is that many parts of the world, the incidence of STEMI is actually increasing and it's occurring at a younger age. So this continues to be a worldwide problem. Now, what do we know? So standard of care in 2020 is PCI should use PCI in a timely manner, less than 90 minutes, really, I would hope less than 60 minutes. Short distance transfer patients should be transferred for primary PCI in a timely manner, and the goals would say less than 120 minutes. But I do think that long distance transfer of patients with expected delay remain an area of controversy, and that we'll talk about, but I think this would fit into what I call pharmacoinvasive therapy. Now, what do we know from regional STEMI systems and what you can do with primary seat? You can do it fast, you can save lives, you can expand the benefits of PCI, you can do it accurately, you can decrease the number of patients with eligible when untreated, you improve the outcomes of patients with cardiogenic shock, you improve the outcomes in elderly patients, you improve outcomes beyond mortality, And all of those things have been shown. And I think by putting in standardized systems to do regional systems of care for STEMI, and I love this quote, humanity's greatest advances are not in the discoveries, but how those discoveries are applied. So I think this is still true in all parts of the world, that we need to have systems of care to deal with STEMI, but not just STEMI, all acute cardiovascular emergencies. So then what we're going to focus, what are those key components? Have standardized protocols, have individualized transfer agreements. So every hospital in your country should have a plan of how do they get to a PCI center, and that should be set up ahead of time. And 3, single phone calls to activate the system. You want to empower the emergency department, even better, empower the paramedics. You want to do extensive training so that the system knows what they're doing, and then you need to do good feedback and quality assurance to make sure your system is still doing well. So that's what we know. That's what works well. Now, what about new research? And I call these research refinements. What's the best optimal antiplatelet or antithrombin? What's the stent choice or design? Radial or femoral? Thrombectomy use? Post-conditioning? And I think all those are relatively minor, and as long as you have a standardized protocol. But I'm going to focus on what are the main issues that are challenges for STEMI. And to Murmad's case, I put number 1 up as multivessel disease and the culprit versus non-culprit. So these are the challenges in STEMI. These are things in STEMI that we need to know. We know with multivessel disease, 40 to 60% of patients have multivessel disease. If you're in cardiogenic shock, it's more like 70 to 80%. There's clearly a worse clinical outcome. And the issue is, when should you intervene, and what's the data, and how do you decide? So we've gone, as we said, from class 3, don't do it, to now it's a class 1, and the question is the timing. And this is actually the complete trial that we talked earlier about, 2,000 patients in both groups, randomized to complete revascularization. But the point was the timing was not specified, and it could be out to 40 days. And then follow up at 3 years. And then data for both the primary endpoint with CV death or MI showed that complete revascularization was clearly better. And in fact, if you look at the second co-primary output, the reduction in CV death, new MI, or in ischemic-driven revascularization was dramatically better. So complete revascularization is better, but I think the timing remains an area of dispute. And in the PRAMI trial, for example, they did all lesions over 50% at the same setting. In the culprit trial, they did it actually in the same hospitalization. And then in complete, they did it out to 40 days. So I think we don't know the answer to that yet, but I think clearly the answer is complete revascularization for the STEMI patient is indicated. And so then, if you want to look at cardiogenic shock, and Murvat also brought about that, the initial results with culprit shock showed that culprit only was better. And then that was true with the primary endpoint as well as all-cause mortality. And so that changed from the 2A, and it changed the guidelines to say that this is a 3B. In other words, don't do it. But is that true? So how can do complete and culprit shock really fit together? And I would say that this, I think it has to do with the timing, because if you look at the long-term outcomes of culprit shock, that you actually showed that at 1 year mortality that was now flat, but there was an increase in the need for subsequent revascularization in the culprit-only arms. So I would argue that you still need to do complete revascularization, and that really the complicated issue is, when do you do complete revascularization? Another really important point about culprit shock is 50% of the patients had cardiac arrest, and so the mortality was high, but a lot of that mortality was related to brain death. And so I think there still is more to be learned about the timing of complete revascularization in shock. All right, what's the second one? A really important challenge is in-hospital STEMI. Do you know the highest mortality in the world for STEMI is actually patients who have This is a really important point, and just like you have a standardized protocol for your emergency department, you need to have actually a STEMI in the hospital. And the data we actually published earlier, where we actually looked at putting in a protocol for in-hospital STEMI, you saw that in yellow that the patients who had STEMI in the hospital had significantly higher mortality. And when we put in a standardized protocol, we were able to actually cut that mortality in half. A third challenge is the patient, and in many parts of the world this remains a big issue, and that's the patients who have expected delay greater than 120 minutes. And I think there's three large trials now that show a pharmacoinvasive approach is if you're going to be a greater than 120 minutes to PCI, that the best approach is to actually do a fibrinolytic followed by take to the patient cath lab. And I think the controversial area is the timing. When do you take the patient to the cath lab? The guidelines say 3 to 24 hours. We've actually shown it's safer earlier than that. But the point is, when you have a STEMI system, for hospitals that are more than 120 minutes, you should have a standardized protocol on how to deal with those patients. And that involves lytics and then taking them to a PCI center so that they can undergo PCI within 24 hours for sure, but I would say earlier the better. The next big challenge with STEMI is out-of-hospital cardiac arrest. This remains a big issue. That patients who have both cardiac arrest and cardiogenic shock in STEMI are the highest risk patients, and they have mortalities between 40 and 50%. Cardiac arrest alone is about 25%, cardiogenic shock alone is about alone. So the challenge is this, and the controversy here is hypothermia, and what level of hypothermia, and what do you do for that? And then the point is, if you have a aggressive cardiac arrest system and you do cooling, we've shown that you can actually have a survival to hospital discharge that's about 65%, even in cardiac arrest. So again, this is clearly a challenge. We need to do better. The next big challenge, I think, is advanced cardiogenic shock, and how do we deal with that with the STEMI, because the mortality rates, again, vary from 25 to 50, depending on whether you have cardiac arrest as well. The SKY shock trial classification we just talked about, I think that's a really important concept. What we've shown is as you increase in your SKY shock stage, there's a significant increase in mortality, and this is the data that shows with cardiac arrest. On top of, in red, you see that cardiac arrest plus cardiogenic shock increases your mortality no matter which level you're in. So the combination of cardiac arrest and cardiogenic shock, I think, is our biggest challenge in the patient with STEMI. And so here's what I'd say about cardiogenic shock. Just like with STEMI systems, you need to have standardized protocols. You need to have regional systems that deal with cardiogenic shock and ST elevation MI. The next thing I'll point out, and I'm not going to talk about today, is quality and reporting. But in your STEMI system, it's critically important that you look at your data continually and you get feedback continually so that you know what your outcomes are and that you adjust your system to fit those outcomes. It's really important because I think people think it's all solved and it's not solved. And the last thing I'll say, has really been COVID-19. And what's happened with COVID-19, both the direct effects, because COVID itself increases mortality, but also the indirect effect. So what we did is you scared patients from the hospital so they didn't go to the hospital. And what we did is a whole series of things. We showed in the United States there was a 40% reduction in STEMI activation. With this is actually data from NACME that shows if you have COVID and STEMI, you have a markedly higher mortality, so 30% versus 12% comparable at the same time, and in 6% for historical controls. And the unintended consequences, you saw more people not going to the emergency room, so then you ended up with larger infarcts, people presented later, lower ejection fractions, and higher mortality. So all across the world, we saw a deterioration in care for STEMI during COVID. And this was associated with a big increase in out-of-hospital cardiac arrest, a big increase in late complications of STEMI. And then the last thing I'd say is even with COVID, there is complications related to the vaccine, and it's concentrated in in those who are younger and those who recently had COVID. So top 10 lessons learned: Do it the same way, standardize, have a regional STEMI protocol that has very standardized protocols. Keep it simple. You need teamwork, listen, and teamwork. You need, it's more than just door to balloon. You need to have a standardized protocol with your pre-drugs, your post-drugs, cardiac rehab, and risk factor modification. And you need feedback, more feedback, and feedback to keep your STEMI system strong. And finally, cardiologists need to get over it. You need to activate, use the emergency department to activate your system. And ED docs need to get over it. You need to use the paramedics to activate your system as early as possible. More importantly, to keep a good STEMI system going, you need key people with energy who say, how do we get this done? And there will be challenges. Every STEMI system has challenges. And I talked about some of the key ones, but no challenge is too big. And what I'll tell you from doing this for many years is it's more important than you think. Really concentrate on your STEMI systems because you can make a huge difference. So thank you very much. It's delighted to be here. I wish I was actually there in Pakistan with you, but hopefully this is helpful.
Well, next time, hope you can come. It was an excellent talk. A lot of issues with STEMI you just covered in 10 minutes, but did it very well. But actually running behind schedule. So can we have the AFIC lab connected? While they're, okay, they have it up. So we'll have a discussion regarding the issues that were mentioned in your talk later on. But right now, we're going to the lab, and Dr. Xiaoling Chen is doing this case for a left main trifurcation. Can you please give us... Dr. Chen, can you hear us? Yes. So can you give us a brief clinical history and show the initial angiogram pictures?
Have synergists there.
This is Dr. Numan Nasir as the moderator and Dr. Zubair Akram, and we have panelists over here with us.
2.5 by...
Can we see the initial clinical history slides if you are able to do it? Dr. Nadir, can you hear us?
Hi.
Hello.
We can
Dr.
hear you.
Chen.
Can you hear us?
Yes, we can. We can. Can you please give us a brief clinical history and show the initial angiogram slides and the plan of your
thank you very
procedure?
much. Because
Thank you.
I'm very excited at this moment to work together with my friends in FIC. So I think now is the time to go ahead to introduce the case, please.
So there, can we display the slides on the main screen? Display the slide on the main screen.
Yeah, give me 2.5 stand. Yeah, 12:15.
So,
please.
This is Dr. Nadir with Dr. Chen. I have Dr. Ali with me and Shahid. And our patient is a 64-year-old diabetic who had an anterior MI in July last year. At present, he is having angina class 2. His clinical examination and biochemical profile are more or less okay. An ejection fraction of 50%. And he had an MPI scan done very recently, which shows almost all the territories are viable. We were worried about the LED, and it is almost 100% viable in the LED territory. So this is the syntax score. The patient was offered surgery, but he declined. So we are here with Dr. Chen doing this case.
Thank you, my friend, for your detailed introduction about the case. I think the key issue before the procedure is to perform nuclear test. This is 2.5. Yeah, this is 2.5 by 15. So
do you have the initial angiogram pictures?
Yeah, from the beginning.
Initial angiogram pictures.
Yeah. Next.
Yeah,
okay.
Great.
Yeah, actually, you know, we have 10 multiple views of angiography. Here, let's start from spider view. You can see this is the caudal, right? So because of the overlapping of ramus with RAD, so we need to find out next. Yeah, this is the last shot of spider view. So 40 with caudal 43. So even the arrow is pretty large, but still two vessels overlapping each other, but it's fine. So can we show the iris imaging? So we just work here, and we wired both ramus and RAD. Yeah, sure, iris.
The right coronary was okay?
Yes. Yeah, right coronary is okay, because they studied right coronary a few days ago. So can you say I was right now?
Please.
Okay, please, I was. Please give us some time.
So you have somebody with distal left main, osteal LED, ramus involvement, and a non-dominant circ which is occluded. So in terms of trifurcation, I guess you would be focusing on the ramus and LED as the vessels with the two-stent strategy. And we know what strategy you would choose, and probably just try to keep the non-dominant circ open.
Can see on the left corner. Panelists, can you see?
Yes, we can see, but if we can have the IVUS as on the main screen, can you enlarge?
Okay, right now it's playing. This is the RAD IVUS, right? No. Oh, ramus. Okay, actually, according to the angiography, it could be trifurcation, but some flares looks like very small. So I think we have to leave it alone. So we started to record IVUS from ramus. So here is the most distal segment point. So it looks like 2.5 in vessel diameter. And gradually when we pull the catheter through the proximal, so now you can see there is this is the RAD, right? So I think here should be the distal landing zone for RAD. So the vessel diameter looks like 230, right? And when we approaching the proximally, so here is a plaque. And also this is manual withdrawal. So I think a coronal major calculate the lesion length.
Here's the left ramus, I guess, coming? Or?
Yeah, no more severely calcified lesion, but very tight lesion distal left main. I think here is a very close. Okay, here is the distal left main, very tight lesion,
very severe.
Very tight lesion. Right.
There's some arc of calcium there.
Cool, but but the middle part of the left main still very severely diseased. So because this is the EPO35 guiding, so it's easily to get deep seating. So I started dislodge the guiding and push the wire. So now we can clearly see the orifice of left main. So please be patient. Okay. So we finished the IVUS recording for left main. So according to the IVUS, the reference vessel diameter for ramus is 2.5. This is the, this is the 3.15. Yeah, right. So any comments from panelists? We just work here. So I think
we'll try to get some. Yeah, you can continue working, and meanwhile, we'll try to get some comments from the panelists. We've seen the angiogram and the IVUS study. Professor Zubair, your thoughts?
No, I think we don't need to pre-dilate. Yeah, this balloon just to balloon crush.
RCA is normal, and it's a dominant vessel, and it's a trifurcation.
So usually
although the circ is totally blocked in the distal part, but still it's a non-dominant small vessel.
So
I'll rather treat this with a decay crush from left vein to this LED and treat this side branch, ramus intermediate as a side branch. That will be my strategy.
Okay. We have Dr. Timothy Henry. Did you see the films, and can you give your input as well? Are you still online?
Yeah, I think I agree with you. Clearly, that left main was severe, and as well as the intermedius, and that the circ is small.
Picture, please.
The ramus is quite reasonably big. I mean, would you approach it with a provisional left main to LAD, or would you go with the 2-cent strategy for the ramus as a DK crush, or what would be your approach? And what did you think about the calcification on the IVUS?
Play.
सर स्विच कर रहे हैं ना वहाँ से
प्ले
आपके सामने ही है मेरा ख्याल सर आपका इंटरनेट है ना वो सही नहीं है.
There's a lot of background noise in the lab, so if only people who are
किस पे आ रहे हैं?
So side branch stent is being deployed, and we have a balloon in the main vessel for crushing this stent later on. So you use your regular...
Said this morning, as I said this morning, immediate...
Can you please cut down on the echo?
Yeah, there are two ways to optimize side branch stent. One is to use the side branch stent balloon. Another one, if there is additional side branch taken from the side branch, so we need to use another NC balloon.
So what size?
I start a 2.5 inflation.
Can we get your microphone closer? We just can't hear you well, Dr. Chen. Is it?
12, 14, 12, 16. Down. Okay, perfect.
So this is high pressure infusion with the stent balloon. And what size stent was it?
18. Yes, stent size is 2.5 by 15.
Okay.
So take a photo.
Yeah. Picture, please.
Yeah. Okay. So I think Ramus looks like a very good because the wire in Ramus is run through. Even I dislike this wire, but I think we can use it.
Dr. Noman, I just want to know that it's a trifurcating vessel and the circ is there, although it's distally occluded. But I think still the possibility of plaque shifting to the circ is there. So just want to know from the operator if it should have been wired the circ even
they're
in this
essentially,
case.
because it's a non-dominant circ and it's occluded distally, they're essentially treating it as a bifurcation lesion, but no harm in putting a wire there just to keep it protected.
I'm at 6,
and you know, because it may shut
8,
down, so it's not unreasonable.
10,
So
10, 12,
Dr. Chen, the question is, would you have put a wire just to keep the non-dominant circ open, and in case it just shuts down and issues with flow there?
Yeah, I don't think so, because some flats looks like very small. Even a patient has multiple vessels, but we only need to treat the dominant one.
Absolutely.
So for this patient, yeah, Ramus and IHD are only 2 vessels we need to treat. So after balloon crush,
So what balloon is this in the main vessel you're using to crush?
Yeah, 3.5.
3.5, okay. Right. And what was the size of the left main?
Picture. No. Okay, I'm sorry.
What was the size of the left main on IVUS?
No problem.
Yeah. Because you know, this is a 3.5 balloon, only suitable for proximal ID, but not for left main. So one more picture. No.
And you know, before you, when you crush the side branch stent, you didn't do a non-compliant balloon inflation. There's a lot of debate in the last session that apart from high pressure inflation from this.
One more picture.
We'll have to wait for a few seconds.
Okay.
So in the last session, Dr. Chen, can you hear us?
Yeah, I can hear you very clearly.
So in the last session, there was a lot of debate that once you deploy the side branch stent and you pull back the stent balloon, do a high pressure inflation, but some people are arguing, and apart from the stent balloon, also do a non-compliant inflation of that stent balloon before crushing it. What are your thoughts? Like in this case, you didn't use a non-compliant balloon. You just, so do you normally do that step or you skip it?
Yeah, actually, you know, how about the pressure? Huh? Okay, pressure is off, right? Okay, actually, immediately after stenting side branch, we need to optimize the side stent. This is a very important step to minimize the gap between side stent with the carina. And for this, there are two ways. Can we take a picture?
Yes.
I want to know if there is dissection. Good.
Oh, wow.
Flow is good, right? Yeah, I need one more 3O balloon for me. Because the ID just distal to the back. That is the dissection. So give me
Dr. Nauman.
Is the patient stable?
3O non-compliant balloon.
3O and C?
Are the pressure?
12,
what's the
12 or 15? Pressure is fine.
Pressure is fine?
Yeah.
Okay, sure. Yeah. Can you hear me clearly? I have explained why do we need to optimize such a stent.
I think we'll let you work.
Dr. Nauman,
Go ahead, please.
Yes,
sorry?
There's a question. Yes.
Yes. I'm Dr.
So we'll let you
Nauman.
work while with the dissection, get things more stabilized, and we'll come back with you. And meanwhile, we'll have a discussion here.
Yeah, I'm Dr. Mamoon Qadir. I'm a local cardiologist from Islamabad, interventional cardiologist. I have a question that what would be the advantages or the favorable points in favor of DK crush here as against keeping it more simpler, because we are dealing with a trifurcation here and going with the provisional strategy with the tap stenting with the easy bailout. And secondly, of course, the other colleague mentioned the wiring, the circumflex, but again, that's understandable, non-dominant. But what about, the tap against the DK crush here?
So I think tap would have been a reasonable strategy as well. To be honest, you should use the technique you're most comfortable with. That is the key thing, most comfortable with. So, if you wanted to go with a provisional, I don't think it's totally unreasonable, but likely that branch would have needed a stent as well. So, if you go with the complexity criteria, we'll talk to Dr. Chen. The lesion length looked less than 10 millimeters, and it was a focal lesion. You just balloon the side branch, and does it fix a complex category that he committed to 2 stents? We'll talk to him once he's done dealing with the dissection. Dr. Timothy Henry, your thoughts? You would have committed to 2-stent DK crush versus a provisional tap for this case.
Yeah, actually, according to the definition criteria, so this bifurcation should be classified as complex.
Okay.
So severely osteal disease, lesion length in sub-branch greater than 10 millimeters. And also because the circumflex, the main trunk of circumflex is very small. So here, ramus sub-branch plays a very, very important role. So we need to very carefully to protect the sub-branch. So this is the reason. Okay, which one is? Oh, this is.
Dr. Timothy Henry, your thoughts? You agree with that in terms of your approach in US?
Can you?
Okay. I think the one thing I would have done different, but I think that you would be the right one, but having a wire in the circ to protect it.
Yes. Already, give me 2.5.
Okay, you would have put a wire in the circ to protect it.
Where is the 3O non-compliant balloon? 3O non-compliant balloon.
3O non-compliant,
actually, for this is a very important bifurcation lesion. I don't want to trade off between provisional and TK cost. We can provide very, very confident data evidence to show how TK quality works well for real complex bifurcation lesion. So far, right now, you can see I have successfully rewired the side stent from the spider view. I like the spider view very much. So I'm sure the wire from the proximal cell. Yeah, 2.5 NC balloon and another 3O non-compliant balloon.
So after the dissection that you saw, have you rewired the circ again after the?
Yes.
You've done that.
Yes,
so now you're going for the kissing.
Yeah.
Oh, you have
Yeah, I have finished. Also, for DK question, don't worry about the main vessel because wire is in line, so we can repair the dissection. What's this?
This is 3O.
3O
in the
for
LED.
LED.
Yep.
Is this LED wire?
Yes.
Okay, thank you. So actually, I did not show the baseline angiography from other view. To be honest, from spider view, I revised already. It took a few minutes because very sharp angle, just distal to the bifurcation. So I think this is also another reason why we need to use two-stent technique. So here, this is the 3O non-compliant balloon. I need to do first kissing balloon inflation. As I said, even decay crush sounds like they have many steps. Usually it has 7 steps, but each step is very easy. Okay, now 3 balloon in LID already. 2.5. This new balloon is 2.5 for Ramos. This is 2.5, right? Yeah. Okay.
So using a 3.0 in the LED and 2.5 in the Ramus for kissing first kiss.
Yes. Can you see there is no any resistance to push the 2.5 into the from Ramos? Okay. No, not LED, only Ramos. Okay. 16. Usually, before each kissing, we always recommend to sequential inflation down. So we have inflated also show Ramos. Okay, one more, 6 by 16. Can you see the angiography?
Yes, we can. We can right now.
Okay, down.
Thank you.
Down. So the sequential inflation should be performed by H, minimal 16 atmosphere. So now, when we have finished the sequential inflation for Ramos, it will be there. So I think now it's a first casing.
Dr. Naman, I just want to ask the operator from here.
Yeah, so simultaneous inflation, 6, 8, 10, down. So you can see LED balloon is a little bit sleepy, right? Yeah. So it's not good. It's not
for sequential, you use 16 atmospheres, and for the kiss, normally 10 to 12 atmospheres, huh?
Right.
Yeah.
12 going up simultaneously. Right. This is very important. Okay, down. Because the LED is
slipping down.
Has a very sharp ending. Sharp bending. Okay, let's start from LED. 6, 6, 8, 10. Okay, Ramos 6. Down. The two balloons separated each other. This is because in proton LED there is a calcification, right? Yeah. So we have 2 overlap a little bit long. Okay.
Can we check with lab 2 if they're also ready for us? We can share the case while they're working on this.
8, down. Okay, I think it's fine. This is the Ramos balloon, right? Okay, let's remove the Ramos balloon. And even we have performed first kissing balloon inflation.
Yeah? It's stalled though.
So, we've switched to lab 2 now, and Dr. Suhail Khan and Dr. Asif Nadeem are doing the case there. It's a bifurcation, left main bifurcation rota case. Dr. Suhail, can you hear me? Noman here.
Hi, good afternoon. Can you hear us from
Yes, we
lab
can.
2?
Can you share the initial brief clinical history and angiogram?
Yes, my colleague, so welcome to AFIC Lab 4. I'm here with Dr. Asif, who's going to be doing the case, and Dr. Sadaf is just going to present the slides. So can we have the slides up, please? Just one second. Yeah. Can you hear Sadaf?
We can. Can you? Yeah.
Yeah. Okay, go ahead.
Next slide, please.
You can continue on. We can hear you. There is a.
Okay, so what we'll do now is we're just going to share the angiogram with you so that you can see what's going on here. Can we go to the angiogram pictures, please? Okay, good. So as you can see, following his radial angiogram that he had, unfortunately we couldn't feel a pulse at the right radial. It was very weak. So we've gone for a femoral approach here. So this is a 7 French guiding catheter. We already know what the anatomy is here. We know that he's got distal left brainstem disease with disease in his proximal LAD and disease at the ostium of his circumflex as well. So next picture, please.
And if you don't have an IVUS, you can see a tram track appearance of the calcium in the left main going to the LAD. You know it's going to be more than 270 degrees arc of calcification when you do an IVUS on an angio like
absolutely.
This.
So I'll just panel what they feel should be the strategy here. So this is the AP cranial shot, and you see that there's a very tight stenosis in the proximal LAD and slightly reduced flow in that LAD. So we're talking sort of TB2 flow in that LAD. Next picture, please. So this is a steep cranial picture, just opening out that proximal LAD. And as you've said, Naman, there's heavy calcification here in the proximal LAD left brainstem complex. So what I'm going to do is just hand back to you now and just sort of gauge some of the opinions of the panel and see what they feel.
Have you already done an IVUS? You want to share that before the panelists make up their mind?
Yeah, I mean, I'm happy to do that. So, yes, why don't we go to the next picture then, please? So, next picture.
And next, please.
Okay, so our strategy here was that obviously I think we felt that we needed to know a little bit more about what was going on at the ostium of that circumflex, because that was going to help us decide what our strategy was going to be, whether we should go with a 1 stent strategy here or a 2 stent strategy.
And geographically
so
look like you could get away with 1 stent, but that's why you need imaging, yeah.
Yeah, no, absolutely, and actually that was my feeling as well. But it would be always nice to confirm on the IVUS as to whether or not we should go with a 2 stent strategy up front here. So the IVUS area on the IVUS, can we share that IVUS area now, please? Oh, can you show? Yeah.
IVUS screen, please.
So we're just bringing that online. I don't know. Do you want to guess what you think the area is going to come out at the ostium of the circumflex?
So, I mean, angiographically, it looked like the circumflex was going to be okay, and left main to LAD strategy, and you'll probably need rotablation before you to better optimize the lesion area before you PCI. We lost connection there. What happened? Okay. So, any comment from the panelists while they're trying to reconnect? What would be your strategy for this patient?
I think, Dr. Naman, here we see that LAD has got long diffuse lesion right from the ostium. Circ, I think, angiographically it doesn't look significant. And I think before proceeding for further intervention, it needs to have IVUS. Through IVUS, we can assess how much calcium.
If you didn't have an IVUS, then you would probably stick to a single stent in this case.
Exactly. Yeah, we have to.
As is the case in a lot of labs. Professor Shai? Left main to LAD. Would you use a rota before, since it's a lot of calcification, this kind of almost tram track appearance there probably is going to have more than 270 degrees arc.
IVUS now, let's see
what
that. Does it show.
You want to make us guess what the IVUS will show, so your thoughts?
So I think doing the IVUS is important, and my other concern is the LAD flow is not great right
so
now.
So are you concerned about using a rota in somebody with a sluggish flow?
Unless we can find a reason and we can fix it, I think I'd be thinking twice about rota.
Yeah, that is a major, absolutely. Yeah. So somebody with a sluggish flow using a rota is always a concern of...
Why is that?
So would you actually balloon it first?
I would actually IVUS the LAD as well, find out if that mid lesion is real.
Okay.
And we can improve...
so let's see what the IVUS showed. Can you hear us now? I think we lost connection, but you're back. Can you show the IVUS now?
Trapped wire. Oh, shit.
Oh, they lost.
Take it.
We can...
Look at the tip of that wire. Tell me what you think. It's knackered, right? Feel it. Okay.
Do you want us to go to the other lab while you're sorting out things here?
इसको थोड़ा आगे करेंगे हम.
अच्छा, रोटा करने लगा. You
There?
And then further.
Further in?
All right, so you're starting the rota. What size burr are you using?
There, yeah.
I know it has. I'm just telling you.
We can hear you.
Brake is on.
Okay, so donor, yeah. Okay, so you screen and rotor at the same time.
Yeah.
You tell me 5, 10, 15 there, so
yeah,
go.
No, have they
No,
shared their IVS information?
I'm going to do the burr.
Have they shared their IVS findings with us?
No, don't say.
They're doing the rota now. After that, I guess now this is in the middle of doing it. Let him finish with that.
153, 10 seconds. 160, 150.
Save that. Okay.
Are you able to communicate now, Suhail? Can you hear us? Can we check? Maria?
15695, 10 seconds.
I think that's enough, right?
Yeah.
415.
Safeties.
Suhail, can you hear us?
Dino.
तो देखते हैं आपका flow का concern जो.
You just pull it back. I'll watch the wire.
Yeah. Wire के tip दिखाएंगे.
Just keep pulling.
Can I just
Wire
make
के
a
tip.
small comment? I think the IVS probably wasn't done
Can
to
I have
the
the
LAD.
fine cross?
Maybe the LAD
Fine
lesion
detector.
was quite tight and heavily calcified, of course. So the IVS catheter couldn't have passed.
So he might have just done a left circumflex to left main to left circum to see that area and not
the
the
decision was already clear
bleed.
from that, you know, that
LAD
you're going
probably
with
knew
the...
what you're going to find.
Now he may have to do the IVS later on once the area is open.
Yeah, big loops. Yeah.
Do we
There you
have
go,
communication? Can you hear us?
Okay, good. So are we live or live then?
You are live, but
Hear us, please.
उनको या तो phone पे ले ले.
Okay, so we are going to change the wire now?
Yeah.
Or wire अपने हाथ.
अच्छा छोड़ दें इसको. Can somebody tell me if can you hear us in the auditorium?
We can hear you, but can you hear us?
So probably our audio is not going there. Can you see the tip?
Not yet, keep going.
Do we have any of the speakers online? We can take them while we're having problems with communication.
There. That's fine. Okay. Just inject saline there. You inject that?
Yes.
Yeah.
So, Dr. Henry, while they're trying to establish communication, what would you have done in this case? And Dr. Esanak, also your thoughts, if you're online. Dr. Henry, can you hear us?
2.5 balloon there. It's already there. It's already there.
सबसे communication खत्म हुआ.
I think Dr. Naman, till we get connected, just on the previous case, when there was, while crushing the stent in the ramus, there was dissection. So generally, although we come across such cases, I mean, the length of dissection was around 10 to 15 mm. So how do you generally, I mean, the operator's approach in such cases, the balloon should be longer instead of the balloon just landing in the dissected part, because the chances of dissection extending further is high.
I actually can't hear you with the echo. Can you mute them while we establish communication so that we can have a discussion here? Okay, Dr. Naeem, yes, can you comment on this case? Did you see the pictures? सबके साथ ही communication disconnect हुआ अभी तो अभी आप so आपका question था if you crush the side branch stent with the main balloon तो what was
and we got dissection there.
Yes.
Now, that was crushed with 3.5 balloon initially.
Yes.
And then again, we needed a balloon.
Yes.
So the second time, generally, when there's dissection there up in the proximal LAD, won't it be better to have longer balloon the next time instead of the balloon distal edge landing in the dissected zone?
I mean, you can't predict that, but if you want to cover the diseased area before and next to it, but
the disease plus the dissection part, the chances of dissection extending into LAD is always there.
I think we lost all communication here. So while we are waiting, so we have this case with which we are talking about on the angiography, a single stent strategy, provisional approach. Most of us were talking about doing that, and I think that's what they're going with after rotablation. Dr. Sunil Rao is with us as well. Can you hear us? Or Naeem Tariq? Can you hear us, Sunil? Dr. Sunil Rao, can you hear us?
With regard to your point, the ballooning with the decay crush, I think one learning point is that the LAD balloon was well kept beyond the, that's a good strategy rather than you thinking that I would do the stenting of the side branch first and then we'll be taking the balloon. So it's always best to park it distally and you can easily pull back. Otherwise, we would have been in a more serious trouble here.
Something else. He was talking about using a longer balloon to crush. Yeah, I don't know if that makes a difference, but yeah.
No. What actually, I think you're very right. Normally, when we are just we plan to crush the branch balloon, we park the balloon in the main vessel distal to that
otherwise,
region.
sometimes
That's
really
always
a problem
there.
Getting the balloon down if you've already parked the stent and the side branch.
Yeah, that was not my query. My query was we got dissection in the proximal part, and the next time when we took a small...
Can you hear us in the cath lab?
What I wanted to make a
Yes,
point
we
that
can.
balloon should have been longer because there was already dissection.
So, Tahir Saab, your thoughts on this case? Were you seeing this case with in which they just did a rotablation?
Can you hear us in,
and I think they're talking to the other lab. Come back a bit more.
please? Slipped.
Okay.
Please come back just around the bend there.
Sohail, can you hear us?
We can hear you. Are you back with us?
Yes, we can hear you now. We lost connection. So we saw you did a rotablation there, and now you're ballooning it. And what size bird did you use?
So actually, just give me a couple of minutes. We're just going to balloon the proximal segment here, and then we can show you some of the nice pictures and the reason why we ended up having to do a rotablation here. So
while you're working over here, can we go to the other lab and see how they finished on the bifurcation lesion, Dr. Chen?
Yeah, sure. Why don't you just give us a couple of minutes?
We'll go over there and then you can show us how you ended this case.
Yeah.
Okay. Guide us deep.
And then we'll go with the talk after that.
Pressure is better.
Yeah.
So I'm taking it out.
Yeah. We'll do an IVUS now.
Open the distal part.
We'll do a cine now, right?
Yeah. Is the next lab, can we go there, please?
Can you keep him?
Yes, Dr. Chen, can you share where we are right now?
Yeah, done. It's fine.
Can we do a cine?
Dr. Chen, can you hear us?
Ready?
Guide.
We can't hear you, so we'll have to wait for a...
Ready?
Yeah.
Picture, please.
Can you hear us?
Yes, we can hear you now, Nader. Yes, we can. Loud and clear.
Perfect. So now this is still on spine view after first kidney inflection. That is hypo-B dissection.
Yes.
As a LAD just distal to the bifurcation lesion, but TB flow is fine. So this is real non-compliant balloon to inflate at the site at a relatively low pressure, 6 atmosphere. Next. Lines expedition 3/33, right?
Mm-hmm.
According to the baseline IOS, so the distal landing zone should be
should be at the distal mark of stent balloon.
So what was the size of the LED? I thought you mentioned it was, what was the size of the LED?
3.0.
3.0, and the left main was 4?
Yeah. Left main is 4.2.
4.2.
So it's easy, yeah, it's easily for the eyes to get 4.5.
Okay.
Next. So stent is inflated very well. So after that, next. So I perform sequential post-dilation. Starting from 3.0, this is 3.0 NC balloon. Next. Yeah, next. This is still 3.0, right? Next. Yeah, this is the 3.5 NC balloon, only
Okay.
for proximal AD. Finally, next.
And now
This is the 4.0, right? Next.
4.0 port, okay.
Oh, this is the 4.0 NC balloon.
Okay.
So sequential inflation is important for tapered vessel disease, particularly for
Now you're
middle
gonna-
AD to left main. Next. So after that, I think this is a final shot before final kissing balloon inflation. We write over here, and I'm trying to rewire ramus. Okay, any comment or question?
Yes, so now you're rewiring the side branch for the final kiss and pot. What wire are you using?
Yeah, still.
Any preference to
BMW.
wiring after at this stage when you rewire the vessel?
Yeah, I always prefer BMW W wire for the
Okay.
wiring. But you know, for this patient, there are two very sharp bending. One is at the proximal ramus, another one at
And
the,
there's always a debate of whether to cross proximally, distally, in the center. So do you really, what is your preference as to where you would cross into the side branch?
Yeah, always I recommend from proximal cell, but for some case, from rewire from middle cell is acceptable. Here, you know, I try to rewire from the proximal cell,
Okay.
but there is a sharp bending at the proximal ramus, so I think it will be a little bit tough to rewire from proximal cell. Otherwise, I will change the wire or change the rewire position. Thank you.
Thank you.
So can you say the wire is smoothly in?
While
I
you're
don't
doing
want
that, we're going
rewire.
to switch over to the next, we're going to get a talk done and then come and see the final result. So do you have the speaker
Okay.
ready? Thank you. We'll keep,
Thank you.
let you keep working there.
Very tortuous here. Very strange angle. So here there is very strong resistance from the
Dr.
YC.
Sunil Rao, can you hear us?
Can you test it for me?
Yes, please.
Yes.
Can you connect us to the speaker, please?
Check, please.
Yeah, can you test? Okay, good. So the orifice of ramus is very strange. So probably I need to use another run through. So can you give me another?
Yeah. Hi, so we have Dr. Sunil Rao here with us, and he's going to thank you for joining us and giving this talk. He's going to talk about a case of a patient with high bleeding risk and acute coronary syndrome. It's going to be a 10-minute talk, and we'll have a 5-minute discussion on it. So thank you. The stage is yours. Please, we can get started.
My slides?
Not yet, if you can share them.
Yep, I'm sharing.
Yes, we have them now.
Okay, great. So thank you very much again, Bashir, for this wonderful invitation to this fantastic conference. I'm sorry I can't be there in person.
Well,
so I'll present a case that's a fairly complex case of a patient with a high bleeding risk and complex coronary disease. I have no consulting relationships with industry that are relevant to this particular talk. So this is a 73-year-old male who presented to our hospital with a non-ST segment elevation myocardial infarction. He has a very complex medical history with a history of cryptogenic cirrhosis and has maintained Child's Class B. But because of that cirrhosis, he has portal gastropathy. He's also afflicted by myelodysplastic syndrome and unfortunately has pancytopenia with a hemoglobin That usually is between 7 and 9. His physicians try to maintain him at around 8. His admission hemoglobin at the time of his presentation with a non-STEMI was 6.9 grams per deciliter. He received 1 unit of transfusion and was treated primarily with just aspirin, no anticoagulation, antithrombin therapy, no P2Y12 because of his overall hematological status. He continued to have persistent symptoms, including angina at night, necessitating quite a bit of intravenous nitroglycerin despite medical therapy and transfusion, so he was referred for cardiac catheterization. We approached this case for invasive risk stratification using right radial approach. Here are pictures of his right coronary. You can see that it's a fairly large caliber vessel, but on the right-hand side, you'll see that he has a fairly calcified, very, very tight lesion, almost looks like a calcified nodule in the proximal portion of the right coronary. Here's his left coronary system. You can see that the left main is narrowed diffusely throughout. His LAD also has a proximal lesion that's hidden a little bit by the circumflex. And while I'm not showing you the angulation of the circumflex very well, there's disease in the circumflex ostium as well. And you can see that even before we inject, there is an outline of calcification in the LAD and the circumflex. And in the right-hand side, you can see that there's an OM lesion, towards the top of the screen, which is fairly tight. So this patient with a complex medical history has a history of 3-vessel CAD, including left main. So this patient, of course, has the same options that many patients do with this type of disease: continued medical therapy. We could pursue PCI in this case, but of course, we'd have to think about, are there particular stent types that we can use? What about his GI issues and his risk for bleeding with dual antiplatelet therapy? And then, of course, because of his 3-vessel disease, although the syntax score is probably moderate here, his bypass surgery, of course, is also an option. So we elected to take him off the table and discuss with the heart team approach and involved our cardiac surgeons. Our cardiac surgeons reviewed his chart, spoke with the patient, and because of his significant medical disease history, they turned him down for bypass surgery, said that the risk of recovery would be too great in this particular patient. And interestingly, it wasn't because of his myelodysplastic syndrome, it was really because of his cirrhosis. If you look at the data on outcomes in patients with bypass surgery who have cirrhosis, they're summarily very, very poor. So he was then referred to us for additional therapeutic options since bypass surgery was not considered. So we decided to go ahead and do PCI because he continued to have persistent symptoms despite attempts at maintaining his hemoglobin at 8 or even 9, which is higher than he normally would be maintained. We did go ahead and load him with P2Y12 prior to this particular procedure and observed him for a few days to see if there would be any risk of GI bleeding, fully recognizing that GI bleeding with P2Y12 inhibitors can be, in fact, unpredictable and intermittent. But we felt some degree of reassurance with 48 hours of aspirin plus P2Y12 that resulted in no significant or evident GI bleeding. For this particular case, we went right radial. We used bivalirudin in this particular case. It's an unusual strategy for us when we go radial. Usually we use unfractionated heparin. But in this particular case, given his history of portal gastropathy, myelodysplastic syndrome, and thrombocytopenia, we wanted to make sure that the antithrombin effect would be relatively short-lived. So this is a JR4 guide, right radial approach, 6 French. We were unable to initially deliver any balloons, so this is a 2.1 French Tornus catheter that created a little bit of a tunnel that allowed us to deliver a non-compliant balloon. We serially dilated up with 2.5 by 15 NC, then a 3.0 by 15 NC, allowing us to perform intravascular ultrasound. I'm not showing you the intravascular ultrasound images, but then we were able to implant a 3.5 by 15 drug-eluting stent and post-dilated this area into the ostium, and you can see flared the proximal portion of the stent with a very acceptable result in this right coronary. Then we turned our attention to the left coronary system, and we used a 7 French guide using a telescoping over a 6 French multi-purpose diagnostic catheter. This is a sheathless approach to allow us to address the left main bifurcation and stay radial using a larger bore guide. So then in this particular case, we went ahead and stented the OM lesion here with a 4.0 by 15 stent. that you can see that there's a size mismatch between the circumflex and the LAD. The LAD, interestingly, is a relatively small caliber, but it did actually IVUS to about a 3.0 vessel, believe it or not. The proximal circumflex here is also a 4.0 vessel. So we did T and protrude, a tap technique, using actually the circumflex here as the main branch and the LAD as the side branch, primarily because of the size mismatch. We ended up IVUSing this after stenting and post-dilated the circumflex with a 4.5 balloon and a 3.0 balloon in the LAD for kissing balloon inflation. And you can see, again, a very acceptable result despite the calcification. The entire procedure time here was about 20 minutes. And the amount of contrast used was around 160 cc's of contrast. So he was observed for about 48 hours post-PCI for a couple of reasons. One is to make sure that he did not have angina while ambulating. We also wanted to make sure he didn't have any post-procedure bleeding events. We went radial here with bivalirudin, so we weren't worried about access site bleeding. What we were worried about is non-access site bleeding, and in this particular case, we were significantly concerned about GI bleeding. So he was maintained on aspirin and clopidogrel with no GI bleeding, no angina. His hemoglobin was stable at 8.5, which is his baseline, and his platelet count was 22,000. We did not transfuse platelets for this particular case, but we did have them on standby. His baseline platelet count is between 25 and 30,000, so his hematologist felt very comfortable with his platelet count of 22,000, and he was discharged home with a plan for dual antiplatelet therapy for 1 month, followed by clopidogrel monotherapy for as long as tolerated. Now, it would be interesting to hear the panel discussion about this particular plan. After conferencing with his hematologist, we decided on this particular plan to try and minimize the risk of bleeding with dual antiplatelet therapy, and we gave him clopidogrel monotherapy to avoid the direct GI toxicity of aspirin. He was seen in follow-up at 3 months and at 6 months and 1 year, and has been continuing to do well from his coronary disease status, although his cirrhosis is progressively getting worse, and my understanding is that he was recently listed for liver transplantation. So that's the case discussion, and I'd be happy to hear any comments from the panel on this fairly complicated case of a patient who falls probably in between all of the particular data and evidence that we may have in the guidelines. So thank you very much, and I'm happy to hear any comments from the panel.
Yeah, excellent, complex case that you presented, an excellent result that you got over there. So it is a very complex situation. What stents did you use?
So we went with, these are Xience stents in this particular case.
Xience stents, and any preference of stents? Like there's a data with Onyx with 1 month, dual to monotherapy with Xience also. Do you think that data is robust enough?
Yeah, so it's a great question. As you know, we have 4 commercially available drug-eluting stent platforms here in the United States. Mm-hmm. We have Orsiro, Synergy, Onyx, and the Xience SkyPoint. All of these stents have some degree of data with shortened dual antiplatelet therapy, whether it's 1 month or 3 months, and some of these data are not randomized. But I think that we can all feel pretty comfortable that it's likely a class effect of these new, the current contemporary drug-eluting stents, that you can get away with 1 month of dual antiplatelet therapy. The way that I interpret the data is that obviously longer is preferred, but if you need to stop earlier, then I think the current generation drug-eluting stents give you a relative degree of reassurance that that's probably safe.
All right, and we have some international panelists with us as well. If Naeem, Tahir, Khaili, or can you hear us? If your thoughts on a case like this, how would you have approached? Or Dr. Imad Sheban from Italy? Yes.
Case, and I think the data involved short depth and Onyx data is randomized, and I think 1 month, 3 month depth, and stopping the platelet after that, just leaving aspirin only or the P2Y12 only is very reasonable. Unfortunately, this data is not translating into where interventional cardiologists being able to follow this. So I still see bare metal stents being put in this sort of situation. So I think this is a great point that Rob brought up. Our new thin structured stents really can be used for 1 month to 3 months. That can be pretty safe.
Yeah, that's a very, very important point. Thank you for bringing that up. We oftentimes get referral cases from our non-invasive colleagues with these high bleeding risk patients asking us to put in bare metal stents. And then we oftentimes have to remind them that this is not 2006. These are contemporary DES that in the meta-analysis done by Steve Ellis's group at Cleveland Clinic actually show lower rates of stent thrombosis, even with abbreviated dual-linear platelet therapy compared with bare metal stents.
Do you think bare metal stents should be even available for coronaries now in this era with the data we have?
Yeah, it's a great question. It's a great question.
They just expire sitting on the shelf.
Right, that's true. I guess I have two thoughts about that. One is as a practicing interventional cardiologist, I like to have options. However, as a cath lab director, I understand that budgets are limited. So I'm of two minds of this. I do think that if you take them off the shelf, I don't think anyone would actually even notice that they're not available.
Yeah, that's we have Dr. Tanvir Rab from Korea as well. Your thoughts regarding this high bleeding risk complex case? I've had a patient with cirrhosis like this as well. His platelets hang around 30, and I've had him in clopidogrel. It's been a few months out. Knock on wood, he's doing okay so far. Yeah, but always a difficult situation. Is Dr. Rab from Professor Rab from Korea with us? So I think Parvez Miraj is ready. So we'll go to the next talk. Thank you, Sunil.
I think Noman, just Sunil, I think a great case and left main in RC Osteal, the major vessels are dependent on them. I think here, instead of just fixing these drugs on the first day for 1 month, isn't it better to follow these patients with dual antiplatelets? I mean, the fear that we have, a patient may do well, may go well with these dual antiplatelets. If we follow such patients after a month and continue for another month, so that we can take care of these stents.
So the question is, if he wasn't bleeding and stable, would you have continued to dual antiplatelet to wait for an event before you change to single antiplatelet?
So that's a great question, and that's actually the crux of the discussion that we had upon discharge with our hematology colleagues. I think and I think that's a very, very good strategy to continually assess and make sure, and then continue it until some adverse event happens, or you reach the 6-month point or 12 months. I think that concerned us was that oftentimes when we see stent thrombosis with antiplatelet therapy cessation, there's usually some other inciting event. It's a bleeding event, or there's some surgery, there's some stress that occurs. And as you pointed out, these are proximal lesions. So I think our fear of the consequences of stent thrombosis in a patient like this, because of a bleeding event that would be the inciting event, worried us. So, but you're right, we did follow up with the patient at 1 month and continue to follow the patient regularly. But I think your strategy is actually a very, very reasonable one.
Just sharing one personal case with you, I had one such case 3 years back, triple vessel disease, and he was just losing blood from GI. So the fear was LAD proximal, RC proximal, circ proximal, and he was getting anemic. We kept that patient for a year, and when needed, blood transfusion used to be done with that patient. But he went well with those 2 antiplatelets drugs, I think, with the dual. But that was the main fear, although the fear is anemia, but again, the fear is with these stent thrombosis, stent occlusion as well.
Thank you, Doctor. Is Dr. Parvez Miraj ready for this talk?
Yes, sir.
Okay, thank you for joining us. Can we have his... We can hear you, but we can't see you right now. Yes.
Hear me now? And
yes,
you should be able to see my slides.
So it was a really nicely done DK crush case, that bifurcation stenting you did that day. And thank you for joining us today for this presentation. So
thank you.
He's going to talk to us about a case of acute myocardial infarction with cardiogenic shock, how to approach. So, all right. Can you share your slides?
Good morning from New York, and assalamu alaikum to everybody, and good to see some friends.
Quite an early morning for you, huh?
Yes,
on a weekend, so.
That's okay. We don't mind. We appreciate it. Honored
Hopefully
to have you.
We can have you join next time as well, physically. All right.
Great. Thank you for inviting us today, and thank you for inviting us yesterday for the live case. We had a lot of fun. Hopefully you did too. Sunil, hello. Good seeing you. All righty. So we are going to talk about a case of AMI shock. So this is a 68-year-old gentleman with hyperlipidemia who presented with 1 hour onset of substernal chest tightness. He was eating lunch with his family, at a restaurant, and he developed subdural chest tightness while he was eating. He initially passed it off as indigestion, but it persisted for about 5 minutes, at which the family said, absolutely not, we're not sitting here anymore. We're going to take you to the emergency room. And I'm glad they did. When he arrived at the emergency room, this was his EKG. As you can see, it does not meet traditional classic STEMI criteria. However, anyone who sees this EKG and anyone who's seen this EKG in the past knows this is not a good EKG in the setting of having acute onset substernal severe 10 out of 10 chest pain. So when we brought him to the cath lab, his blood pressure was 70/30. His heart rate was 130. His respiratory rate was 40. He was satting at 90%. And as you can see here, we very quickly did a ventriculogram, and the ventriculogram showed that his EF was severely depressed. We then take a picture of the right, and he's fortunate to have a relatively reasonably good RCA. But if you look at the left system, you can see here this was his issue. Very, very unfortunate, and it's extremely lucky for him that he's actually still alive coming to the cath lab, because as we all know, the vast majority of left main acute occlusion STEMIs don't really survive to the cath lab. They usually arrest before they make it to the cath lab. So he was very fortunate that he made it, and he should be thanking his family for forcing him to come to the hospital as fast as they did. So questions for everybody. So what do we do now? You know, and obviously this is an international conference. So what we do in New York is probably different than what we do across the world. We call a surgeon. Do we just start with opening the left main?
And geography minus kare. Minus.
What kind do we do? So mechanical cyclotrons.
I think why don't you just carry on and we'll have a discussion in the end.
Absolutely. I'm just putting the questions out there for everybody that we can talk about later. Mm-hmm. And then do we do a balloon pump? Do we do Impella? Do we do ECMO? Do we do tandem heart? Do we just call for help? There's so many different options in so many different ways. And I think this will be an interesting conversation at the end of the talk to see how everyone around the world does it differently. I will tell you a little bit of our strategy. So just to quickly review, you know, we obviously are big proponents of identification of the shock. You know, I'm not going to go into the details of this, but identification of shock, confirmation of shock, and prognostication of the shock. Very important to have a right heart cath, you know, to understand where we are with shock. In this particular setting, you don't have the luxury of time to really do anything except really get to the patient as quickly as possible. But in most cases, you can identify the shock quickly, which I think everyone would agree this gentleman is in cardiogenic shock. Just from the phenotype of it. The confirmation of shock we would get with the right heart cath, and the prognostication also with the right heart cath. And if you look at the SCAI shock pyramid, as we all have seen, this has become such a useful tool for us, and it's becoming even more iterative now with the more recent publications in terms of not just the phenotypes of it, but how they actually present and what their outcomes and trajectories are. This patient was definitely in at least stage D, and not quite at stage E, but was probably going to go to stage E very quickly if we did not get to him as fast as we did. And that obviously has a different trajectory and outcome. So we all know there are ways of improving the hemodynamics, pharmacologically, inotropes and pressors for those blood pressure agents. And obviously we know, unfortunately, these agents are useful in increasing the blood pressure, but they are poison for the heart. They don't really produce any kind of beneficial effect to the heart, especially in acute MI shock. And their devices, and there are many devices. There's balloon pumps, there's tandem heart, there's ECMO, there's Impella, and all the devices are great. All devices have a place in this world. None of them are equal. They all do things a little bit differently. And I think it's important that we recognize that. And the last thing I'll bring up before we talk about the actual cases, one thing we must always remember that, you know, opening a blood vessel in the setting of shock is great. I think we have to just keep in mind that there's the coronary perfusion pressure is really your mean pressure and your gradient between that and your LV-EDP. And if someone's LV-EDP and their mean arterial pressure, like in our case, was about the same, no matter what you really do to opening the blood vessel, until you improve the hemodynamics of the patient, it's not going to really change the perfusion pressure. So I think this is an important concept, and I think it's an important reason why historically we have not really done well in treating patients with cardiogenic shock, and their outcomes have not been improved. And I would say more recently, with some of the systems of which we'll talk about later, we've seen some improvements. Another factor that all of us should really in interventional cardiology never forget is our PV loops. It's an important piece of information and an important understanding. Just to understand PV loops, basically, we have the normal cardiac cycle here on the left and what someone goes into cardiogenic shock. As you know, the LVEDP is on this right bottom corner. It increases, the contractility curve goes down, and obviously the stroke volume decreases. So it's an important concept to understand what's happening here and what we can do to improve that. So what we did is we went ahead and took a picture of the groin. Unfortunately, he had some peripheral arterial disease. We actually placed a balloon pump initially and started to simultaneously try to fix the coronaries. I was very fortunate that this case was happening at the end of the academic year. And so my interventional fellow was actually extremely adept at helping me out, and I wasn't alone doing this on my own. So we were able to do things simultaneously. So we initially placed the balloon pump, we started getting opening, and you can see we restored flow to the left system at least, but the patients continued to spiral. The pressures continued to go down. We continued to have escalating doses of pressures. He needed to be intubated urgently. And so, you know, at that point, we felt there was not a whole lot we could do in the current setting, and we needed to escalate care. The balloon pump just wasn't enough. Because of the PVD, and this was the time before I was doing axillary impellas, you know, we decided to fix the external iliac artery, and then we went ahead and placed an impella, removed the balloon pump, and then continued to proceed. Once we placed the impella, his hemodynamics began to stabilize, the pressure escalations began to decrease, we were able to manage his acid base a little bit better, and things started to improve. And we were able to finally fix the left main LAD circ bifurcation and got a pretty reasonable result considering the situation. We then went, and this is the final picture on the left, and I showed this picture on the right because we didn't have the time or the luxury of time to place a swan, but we did place a swan at the end of the case, and I think this is of critical importance to really understand what the hemodynamics are, because in many of these cases, an impella just may not be enough. We may need to even escalate to an ECMO. And so we kept the patient in the lab, we checked the hemodynamics and made sure that we were in a good place before we left the cath lab. So in summary, we had to understand the hemodynamics. We really had to have invasive assessment and therapies to likely improve the outcomes. We utilized all the information we had at the time to really help guide our therapies. We started doing everything all at once. And we did start MCS early. We started with a balloon pump, and we realized the balloon pump just was not enough, and we escalated to an impella. We really need to change the conversation, and in the United States, there's a lot of controversy over percutaneous LVADs, ECMO, balloon pump, and everything else. And I think the conversation really needs to change until the data comes out to suggest that, you know, we probably have more than one strategy and more than one way to treat these patients, and really every patient is individual, and try to individualize the care of these patients. Care-tailored therapy, like I said, is really of critical importance. This particular patient, just to give you the summary, was in the hospital for about 5 to 7 days, ended up getting explanted with his impella. His EF was still about 35% at the time of discharge, but he actually walked out of the hospital on his own accord. So an amazing story, an amazing case, and very fortunate for him. One plug for our SkyShock meeting. We put on the SkyShock meeting. I'm fortunate to be one of the chairs with Bob Robespierre and Alex Truesdale. And we invite you all to come and join us. We'll be talking about a lot of this, the more detailed therapy, more detailed story. And that's all I have. Thank you very much for the invitation.
Thank you for sharing the case. A great safe indeed. You know, as complex as it gets, and you know, using all your resources to save him. So, any thought from the panelists?
Great case. I mean, it's very, very challenging. These cases are really tough. And I think one of the big challenges of cardiogenic shock is that, you know, there are patients like this patient who will tolerate this for a little while with hypotension, and other patients have out-of-hospital cardiac arrest. And it's just hard to figure out, you know, we're just not smart enough to figure out who's going to present in what way. But you know, it's a great case, and I would have done exactly how you have done this particular, or how you approach this. I mean, it's really, it was really, really well done.
Sanili, I agree. I think that is one of the inherent issues in shock, right? I think it's the diversity of the presentations and the phenotypes of the way these people present. And very, very few times you'll see two people, albeit with the same acute MI anatomy, but presenting differently hemodynamically. And some people just have more tolerance than others. And I think this is part of our problem in terms of the data for this society, for this area. It's just two people just aren't the same.
So just a quick question. Would you have changed your strategy if after wiring you didn't have flow?
Meaning with the balloon pump you're saying?
Yeah, so I guess the question is, would you have still proceeded with putting the Impella first before doing the PCI, or would you have done, say, a thrombectomy or a balloon just to conserve time? Would you have changed your strategy in any way?
Right, I'll tell you from our experience and from at least from the relatively retrospective data that's out there, it suggests that, supporting these patients, even in the IBP Shock 2 trial, it showed that, patients who had balloon pumps put in before their PCI actually did better than those who did after in the sub-analysis. So in my humble opinion, I think, in this kind of an extremis patient, unlike someone who's not in shock, I think it's important to support them before you proceed with the PCI with something. Whatever you have available to you at the easiest. So I would have still probably put the balloon pump in. I would have still proceeded with the PCI, and I still would have probably then, based on the hemodynamics, would have then escalated as necessary.
So we don't have Impella, but in US also, physiologically, it makes all the sense to have used Impella over here and provide them with intra-aortic balloon pump support if you don't have that. But there is no data to support its use, and I know it's very hard to do trials in these shock patients, and we're still looking forward to having a positive data from Impella, and I guess with a better comfort with vascular access and management, hopefully with more experience, you'll have better results as well with Impella use in these shock patients, and let's wait for more data as well on that. And this concept of coronary perfusion pressure, of checking the EDP and diastolic pressure, I think that's a basic simple thing you can keep in mind to resolve that post PCI, to help with that as well. So a lot of us don't normally routinely check an EDP, but not a bad idea once you're done to just quickly check an EDP, and in terms of the shock management post PCI with diuretics and support that they need. So I think we have Dr. Dipti Ichipuria, past president of the American College of Cardiology, now available as well to give the talk. Can you connect us to? She's going to talk about most important cardiology trials of 2021-2022. So, good morning, I guess.
Thank you so much.
It's really early morning for you, and thank you for taking the time to join and give a talk. I'm Numan Nasir here from Lahore, and we have a group of panelists and a big audience still waiting. And all right.
All right, well, thank you so much for the invitation. And actually, I'm in Australia, so it's actually late at night in Australia here. I'm at the ASNAP meeting, and so I'm sorry that I couldn't be there in person, but let me share my screen and bring up my slides. I may have to do this twice. Let's see. Can you see the slides, or do you see all of them?
Not yet.
Okay, so let me just do this again. I've done this.
Yes, we can. No, it's per way slide, actually.
Yeah. Okay, how about now? Can you see that?
Not yet. Can we look into that? Slides, Dr.
Those of us who are virtual
can see your slides
them.
now. Yes, we have them.
Perfect. All right, so I am going to be talking about the important trials from the past 12 months in interventional cardiology. And, there's been a lot going on, even though we've all been virtual and really coming together for the first time. I have no disclosures. So I really was hoping to talk about some slides that have been, some trials that have been published in all the various journals, and really talk to you about 2021 and 2022 in a nutshell. Let's start off with Fahim 3. This was presented by Bill Fearon at TCT 2021. This is a FFR-guided PCI versus CABG in patients with three-vessel disease. Investigator-initiated multi-center randomized control trial. They took all comers with three-vessel disease, but not involving the left main. And these were patients that were amenable to PCI as well as CABG. So these were patients that had greater than 50% stenoses. And this was 48 centers in Europe, North America, Australia, and Asia. And basically, they did a one-on-one randomization where they put patients in FFR-guided PCI, stenting those patients that had an FFR less than 0.80, and then CABG based on angiography. And then the primary endpoint was MACE at 1 year, all-cause death, MI, stroke, and repeat revascularization. And then key secondary endpoints was 3 and 5 years, but we got the 1 year data here. And what the FAME3 trial demonstrated was that FFR-guided PCI using current generation DES did not meet criteria for non-inferiority compared to CABG amongst patients with revascular disease. I mean, of course, when you look at the safety endpoints, you see increased arrhythmias, and that's to be expected in the CABG group. So there was nothing new in that, but it did not meet non-inferiority. Now, the follow-up trial was a FAME3. This was at ACC 2022. This was a quality of life after fractional flow reserve and guided stenting. Now, previous studies had shown that quality of life improves with coronary revascularization, but more so with CABG than with PCI. But the prior studies really did not look at FFR-guided PCI, nor did it really take into account the current generation of drug-eluting stents. So this was all about quality of life. Now, we know the primary endpoint of FAME3, as I just told you, the PCI did not meet non-inferiority, but both study arms really had low event rates, and the difference between PCI and CABG narrowed compared to previous studies. So really the impact on quality of life, chest pain, work status, all of that becomes sort of part of the clinical decision-making as we think about it. So the goal of this study was to compare the effects in these health-related quality of life outcomes, the so-called the EQ5D, and that was self-reported 5 dimensions of health status, right? Mobility, the pain, discomfort, anxiety, depression, all of this was on a 5 scale, and the patients had to sort of be looked at in terms of this European Quality of Life Index. And what they saw was at a baseline very similar, right? You see the CABG and PCI is in that blue, and the red is sort of the CABG. And then what you see is an improvement initially with PCI, but not with CABG. But overall, long-term, you see pretty similar results. When you look specifically at the anginal status, you see that they're pretty similar when you start off. And then as you go along, again, not a huge difference between the anginal status. This is over class 2 angina. If you look at the working full or part-time, interestingly, you saw a higher rate of returning to work at 1 month in the PCI arm, and you saw that at 6 months as well as 12 months. So really, what we saw in patients with revascular disease is the quality of life at 12 months was very similar in the FFR-guided PCI with the current generation of DES compared with CABG, and that FFR-guided PCI resulted in a faster improvement in quality of life than CABG during the first year of revascularization, and this improved the working status, particularly in those patients that were less than 65 years of age, and that the rate of significant angina was greatly reduced in both, but not significantly different between the 2 groups at 12 months. And so I think that although we didn't see the current status of DES meet that non-inferiority, we saw that quality of life may be quite similar, except for if you were a younger person that wanted to go back to work. Now, the next trial that I'm going to talk to you about is the FLAVOR trial. This is the fractional flow reserve versus IVUS, intravascular ultrasound to guide percutaneous coronary intervention. Really interesting. This is something that we use all the time, particularly those of us that are doing complex PCI. We really believe in imaging. We believe in getting the physiologic data. But the question is, do we choose FFR? Do we do an IVUS-guided PCI? What's the best strategy for intermediate coronary stenosis? And so the working hypothesis for this trial was that the FFR-guided PCI strategy will be non-inferior to the IVUS-guided strategy in terms of clinical outcomes at 2 years after the index procedure. And so this was 1,700 eligible patients and about 1,682 patients that were randomized, 838 into the FFR-guided PCI group, 845 in the IVUS-guided group. And what we saw was we ended up with 832 in the FFR group at 24 months and 836 in our IVUS-guided group. And what we saw was that the primary outcome is very, very similar when it comes to IVUS versus FFR in terms of the outcomes. And what we noticed when you looked at the clinical outcomes, when you looked at the death, myocardial infarction, revascularization, IVUS-guided PCI stroke, all of that, very, very similar event rates. And then if you actually looked at the patient-reported outcomes with the Seattle Angina Questionnaire scores, again, no difference in this questionnaire scores in terms of physical limitation, angina stability, treatment satisfaction, or quality of life. So this trial was the first head-to-head comparison of FFR-guided versus intravascular ultrasound-guided PCI for intermediate coronary stenosis. And what we found was that FFR-guided PCI was non-inferior to IVUS-guided PCI with respect to the composite endpoint for any class up to 24 months. Now, the study showed that both are an appropriate initial strategy for intermediate lesions, and they both resulted in reduced resource utilization. Now, I would say that FFR compared to IVUS, FFR-guided PCI was associated with lower rate of stent implantation, which makes sense. If the FFR is not significant, if it's not less than 0.8, we may defer doing stenting, and so that was not unusual. There was also no difference observed in patient-reported outcomes between the two strategies. So again, a good trial, but did not show a big difference between the two strategies. Although I think we could argue that if we had complex PCI, I think that it's important that we do IVUS for planning, to notice about calcification, to know what the plaque burden is. So for planning, and I think, you know, doing FFR is more about whether a lesion is significant. So slightly different, but those are the results. The complete trial is the next thing, looks at the effects of the complete revascularization. I'm sure you've already heard about this trial during this study. And this is really to determine if complete revascularization improves anginal quality, related quality of life compared with the culprit lesion only PCI in patients with STEMIA and multivessel coronary artery disease. Are you starting to get the theme? There's a lot of talking about quality of life issues with some of these trials. We've heard about the complete trial for a while now, but we really haven't heard about the quality of life in this particular case. Again, as you recall what the complete trial was, this was STEMI and multivessel coronary artery disease with successful PCI to the culprit vessel. And again, these were patients that were randomized, a large study to almost 2,000 in each arm, and looked at what their intervention was, PCI in the culprit vessel versus complete revascularization. And then again, asking them about reported quality of life indices. And these were patients that did that and answered all of those questions. If you look at some of the clinical characteristics between the two group in terms of the complete, very similar age was about 62, 79 to 80% males, diabetic about 20%, you know, all of this data you should be quite familiar with. But what we looked at when we looked at the, in terms of angina frequency, again, about 50% reported none in both group, in the complete as well as the culprit only. But some differences are, not really a big notable difference as you may have thought in this particular parameter. If you look at the crossover PCI of the non-culprit lesions after angina-related clinical events, and if you look at the graph on the bottom, which is in black, it's the complete. There was obviously no need for crossover, but the red is the culprit only. And this was all of the culprit lesion only ones were the ones that crossed over because of angina-related clinical events. So they had to go on to have further revascularization. Again, this was the residual angina, the culprit vessel obviously higher than in the complete arm, as again would be something that would be expected, not anything different. If you looked at the predefined subgroups, and you looked at that, what you found was the culprit only is better in the group that had no non-culprit stenosis greater than 80%, or greater than 60%. So if they did not have any significant other stenosis, they were the only ones that did not report, and they were the only ones, that was the only group that did better in terms of the culprit vessel lesion only, but everybody else fared better with complete revascularization. So again, when you look at residual stenosis at mean of 3 years, you're going to see that that there was definitely more residual angina in the group that had culprit lesion only revascularization. And so I would say the result of this study revealed that complete revascularization improved PCI self-assessment questionnaire overall score, quality of life score treatment, as well as physical limitation score and the angina frequency score. Both a complete revascularization and a culprit lesion only strategy resulted in the substantial improvements in overall angina-related quality of life compared to baseline. And so at median age, at median follow-up of 3 years, a greater proportion of patients were free of angina in the complete revascularization arm than in the culprit lesion only, translating into a number needed to treat of 31 patients to prevent one patient from experiencing angina at follow-up for 3 years. So again, I think that the benefit was in those patients that had non-culprit lesions, stenosis greater than 80%. And I think that the crossovers were certainly higher in the culprit. So I think none of this is surprising to any of us, but again, it's nice to have the data to prove that. Now switching gears, what about latest advances in pharmacotherapy? We'll start off with the master DAP. This is a dual antiplatelet therapy after PCI in high bleeding risk patients. This was the first open label randomized control trial in an abbreviated DAP in high risk bleeding patients undergoing PCI. So these were patients that were deemed to have a high bleeding risk, really important. And they were event-free at 1 month after PCI with a drug-eluting stent, about 26% with non-ST elevation ACS and 12% with STEMI. And this was one-to-one randomization with an abbreviated DAP versus a standard DAP therapy. So in abbreviated, they did, they had a shorter course of the dual antiplatelet therapy, but then single therapy for 11 months versus the standard therapy as we normally do. And what we found was the net adverse clinical events were no different. Major adverse cardiac or cerebral events really not different. But of course, as expected, the BARC 2, 3, or 5 bleeding, you would expect the standard DAP to have a higher bleeding, which is what the blue graph shows, and the abbreviated has less bleeding. So this showed in high bleeding risk patients, a shorter course of dual antiplatelet therapy had improvement in terms of bleeding risk, but really no change in terms of the ischemic events. So I think it's really promising to see each year that we have new trials providing insights on a shorter yet safe duration of a dual antiplatelet therapy post-coronary intervention. And I think Master DAP showed that an abbreviated antiplatelet therapy was non-inferior to standard platelet, regardless of the fact that these were high-risk patients. And I think that the findings of DAP are really important and move us towards a shorter and simpler antithrombotic strategy after PCI. And I think this is this kind of goes along with some of the data that has been coming out. And I think that it is important to notice that this trial used a biodegradable stent, and the results may not be applicable to other kinds of drug-eluting stents. Just keep that into mind. The next trial is the STOP DAP2 trial. This is 1 month of DAP followed by clopidogrel monotherapy in acute coronary syndrome patients. So again, you see this laid out. Patients all received aspirin as well as a P2Y inhibitor therapy for the first month. But then after the first month, we only continue with clopidogrel in the shorter DAP trial versus doing both therapies, aspirin as well as clopidogrel for 12 months, and follow these patients. The outcomes we were looking at was bleeding and myocardial infarction. These were patients that were followed for 1 year. And what we saw was, of course, a change in a difference in terms of the bleeding as expected. and again, a higher risk of myocardial infarction in those patients with 1 month DAP. So I think following the results of the master DAP, the main message was that short DAP would reduce bleeding at no additional cost in terms of ischemic events. But I think the STOP DAP trial highlighted the limits of this abbreviated DAP regimen. Now remember, part of the fundamental difference in these two groups was that master DAP was high bleeding risk patients versus acute coronary syndrome patients, which is were the patients that we included in STOP DAP too. So I think that the clinically challenging settings, such as the overlap of high bleeding and ischemic risk, are really not informed by the results of STOP DAP. And I think that post hoc analysis of global leaders and Twilight really indicated that ticagrelor monotherapy could reduce bleeding compared to ticagrelor-based DAP, without increasing the ischemic events. So maybe the message is that a more potent and reliable P2Y12 inhibition could open up that door to the abbreviated course. But certainly, I think that we have to be cautious when we see this. And I think the main lesson appears to be that in current practice, there are limits as to how far we can go in shortening the dual antiplatelet therapy, specifically for clopidogrel monotherapy. And maybe, you know, as I said, using something like ticagrelor, or if we in acute coronary syndrome, I think the key is also the utilization of IVUS guidance to maximize the PCI may be necessary if we're going to do something like have just clopidogrel. So I think these are key messages to keep in mind. So
just last, I guess, yeah, you're finishing up. We've gone over time.
Yes.
So this time, yeah.
Yes, I think I'm just going to go through. Well, I had a couple other studies. I think basically those were the big ones that I wanted to go. So I think we look forward to the rest of 2022 and 2023 and look forward to the rest of the trials. But I really wanted to get out the stuff about the shorter dual antiplatelet therapy. So I'll stop here. Thank you so much.
Thank you. That was a great summary of the trials in the last 2 years, and you know, with the last master DAPT and short DAPT, you know, just using DAPT as a blanket therapy for most patients, you have to individualize with these high bleeding risk and high thrombotic risk patients and tailor it now with all this data coming out, and it gets even more and more complicated with more options. You know, so thank you for trying to summarize for that, and you did very well. And any thought from the panelists? There.
No, I want to say something.
Please, Bashir sir.
Deputy, thank you very much. This is Bashir. I really appreciate for you. I know you are already traveling, and it's very late at night over there, and you adjusted the time and everything. And we are very grateful that you were able to make it and give us this great talk. Thank you so much.
Well, thank you for having me. I really appreciate it. And congratulations on a very successful conference for you.
Thank you.
Thank you for all the summary. You know, learned a lot from that. And can we take to the lab? Do we still have the images from the lab? If they can share if anybody's there.
So meanwhile, can I take a minute regarding this last talk? No, just a minute. I have just one question. It was an excellent talk given by her regarding the FFR. You know, in our centers in Pakistan, if I especially talk.
You're talking about the flavor trial that Dr.
FFR.
Echeverria presented? Okay.
Exactly. You know, most of the centers don't have that facility of FFR, even the IVUS. So for especially the gray zone lesions, for which eyeball decision has to be made, and half of the people are going to do, and half of been deciding we should wait. What strategy we should apply for this patient having the gray zone lesion? Either we should go for the stress thallium, or which is available somehow, or what is the strategy other people can just suggest here?
Intermediate stenosis, in most cases, if it's in a stable situation, if the LV function is normal, you know, you would not want to do anything and treat them medically.
We need that camera on us, don't we?
So, Suhail, unless you have documentation of ischemia, and yes, so can you share the final results? After we saw you were doing a rota, what bird did you use?
Yes. So you can see we finished the case here. We've wired the LED, and we've got a balloon in there. And just before the balloon went in, we tried to IVUS the LED, and we were unsuccessful in passing the IVUS probe. So that's a good indication to suggest that actually this is concentric calcification in the LED. And that was confirmed with the inflation of the 2.5 balloon in that proximal LAD segment. Next picture, please. So that meant that we felt that we had to go ahead and treat this with rotablation. Go forward now, please. Forward. And here, with my practice is to switch over a microcatheter. So we've switched over to a rotor wire with our microcatheter. Just hold this picture. And you can see here, this is a 1.5. What we're wanting to do is to have a pair with an approximate 2-to-1 ratio of the artery size.
We can't hear you. Can you be a little louder? But we can just muffle sound, yeah.
Yeah, can you hear me now?
We can hear you, but really muffled, yeah. Can you move the mic a little higher to your...
Yes.
Still a little muffled, but I guess we can make it out, yeah. Go ahead.